I'm still seeing people join, so I'm going to wait one more minute. Do you remember how many we had registered? Okay, we're at like 123, so you think everybody's on?
It was over 250 is what the email said the other day.
Really?
Yeah, it was
Yeah.
200, it was 258.
But
Okay. Are you ready, Eric?
Yes, ma'am, we sure are.
Okay. Good morning. I'm Kelly Jenkins. I'm the Executive Director here at the Kentucky Board of Nursing. And I'm going to start the meeting today with a presentation just to give an overview of the Kentucky Board of Nursing and the functions. And then each area is going to actually get into some more detail about what they do on a daily basis. The Kentucky Board of Nursing, each state or jurisdiction has a law called the Nurse Practice Act, which describes qualifications for licensure, nursing titles that are allowed to be used, scope of practice, actions that can or will happen if the nurse does not follow the nursing law. So the goal and the mission of the Kentucky Board of Nursing is protecting those who receive nursing care through regulation. Our mission statement: the Kentucky Board of Nursing protects the public by development and enforcement of state laws governing the safe practice of nurses, dialysis technicians, and licensed certified professional midwives. So who is the board? The state government agency governed by the Nurse Practice Act. We currently have 16 members appointed by the governor. 10 of those are registered nurse members, 1 is an APRN member, 3 licensed practical nurse members, and 2 citizens at large. Each member serves a 4-year term. We just recently passed a Senate bill which will actually increase us to 17 members in the next year, and we will have 1 that's going to be a CRNA member. The selection process by the governor is individuals are nominated by their professional organizations and their names are submitted to the governor for appointment. Kentucky Nurse Association, Kentucky Hospital Association, Kentucky Association of Healthcare Facilities, Kentucky Association of Homes and Services for the Aging, and Kentucky Association of Licensed Practical Nurses, and the Kentucky Organization of Nurse Leaders. The license types, this is just giving you a total number of what we have. So about 89,822 licensed RNs and LPNs. We have 11,391 APRNs. We also oversee dialysis technicians, 678, licensed certified professional midwives, 28, and the sexual assault nurse examiners, 343. Most of the meetings of the board and its advisory councils or committees are open to the public. So on the even months, the board meetings are held. On the odd months is when our committee and council meetings are held. Here is our board organizational chart. So as the executive director, I report directly to the board members. We have a legal services section, which we have 2 attorneys on staff right now. We have the agency support branch, which is our administrative and IT support. Credentials is our licensing section. We also house the nurse assistant registry for Kentucky. Professional support branch, which is also our educational consultants, practice support. Investigative branch, which is our nurse investigator section, and investigations, the complaints are taken in first through this branch. And then the compliance branch, which is our case management RNs, and our care program, which is the alternative to discipline, is monitored through there. We have the blue are the committees, which are comprised of board members, and then the green meetings are council, which can also be outside members. So we have the Education Committee, Practice, the APRN Council, Consumer Protection Committee, Governance, Dialysis Technician Council, and Licensed Certified Professional Midwifery Council. The Kentucky nursing laws or Kentucky administrative regulations. So I think of this as kind of like policy and procedures for those that are familiar with the hospital. So our nursing laws are Kentucky Revised Statutes, which is Chapter 314, which is our policies. And then we have the Kentucky Administrative Regulations, Title 201, Chapter 20, which is the Board of Nursing, which is more like our procedures. In 1983, the Kentucky Board of Nursing began publishing advisory opinion statements on various nursing practice issues. These statements are issued as guideposts to licensees who wish to engage in safe nursing practice. An opinion statement is an advisory opinion of the board as to what constitutes safe nursing practice. It is not a regulation of the board and therefore does not have the force and effect of the law. We also have a nursing incentive scholarship fund. $5 of every licensure renewal fee goes to this fund. It is applicable to Kentucky residents attending approved pre-licensure or graduate programs. The programs of nursing do not have to be located in Kentucky. The typical award is $3,000 per academic year. It may be used for cost of living expenses as well as school expenses. And you may submit up until June 8th of each year and actively enrolled in a nursing program. So we are still accepting applications till June 8th, and that can be found on our website. And we're going to take questions, I think, at the end of the program. So we will move on to the next presenter.
All right, I will be enabling Kim Richmond at this time. It may take just a second. Hey, Kelly, you may have to left click on my name and then click make host, or right click on my name and then left click on make host. Thank you. All right, Kim, you are now the host.
Thank you. Okay. Can everyone see my screen and hear me?
Yes, ma'am.
Thank you. Okay, following up to Kelly, my name is Kim Richmond. I have been here at KBN for just over 2 years. I practice as a nurse practitioner and as a house supervisor here in Louisville. I've been a nurse for 11 years now and really enjoy talking with you all about your nursing scope of practice and just the Kentucky Nurse Practice Act to really give you information that will help guide your practice. See. Okay. First, we're just going to talk a little about the professional support branch, what we do here in my branch, and talk more in detail about the Kentucky nursing laws and advisory opinion statements that really relate to and speak to your nursing responsibility and how we are individually accountable for the actions that we choose to do as a nurse. The professional support branch includes my wonderful boss, Myra Goldman, who is also an APRN. She does education and practice. We have all of us that really do a little bit of everything with professional support, but my colleagues, Valerie and Joy, are the go-to for education. And then my colleague, Tina, and I really focus a lot on practice. And then we have assistants, Michelle. Amy recently just left us, so we need to update that as well. But we have coordinators who do continuing education and the Nursing Incentive Scholarship Fund. Here in the professional support branch, we do a lot of education and practice. That includes all of the nursing programs here in Kentucky for RNs, LPNs, and APRNs. We also have the licensed certified professional midwife, dialysis technicians, and SANES. We do the CE and NISF as well. So anytime you have questions about nursing education or practice, or you're getting audited for CEs, my colleagues and I are the ones that you reach out to with any questions. This is a really good diagram that kind of breaks down the statutes, regulations, statements, and opinions. There are all different levels, and you'll see as my presentation goes on that things build. So we have statutes that are set forth by legislative and we have regulations that the Kentucky Board of Nursing really says, hey, these are the statutes. We're going to provide a little bit more guidance and information from regulations. And then when those questions really can't be answered, we have the advisory opinion statements. The statutes and regulations hold the full force and effect of law. However, the advisory opinion statements are just that. They are opinions after consultants and colleagues do some research. We identify these things that may or may not be within your scope of practice. When we have a question that has never been answered or never given an opinion on, we get those sent to the practice consultants and we answer them as best as we can. However, if we don't, we say, we're going to bring this to the practice committee, and then we'll take it to the full board and we'll actually have an opinion on something. So if there's ever questions that you have, feel free to send them to us and we will send you statutes and regulations and the advisory opinion statements to guide you. And then if it's something that we've never answered, we will send that to the committee. Just breaking it down a little bit more. So the Kentucky Revised Statutes, or KRS, are the body of laws that govern the Commonwealth of Kentucky. As Kelly mentioned, the reference we like to give are, these are the policies that we have in healthcare organizations, or really wherever you work at. There are policies that say what is within our scope of practice, what we can and cannot do. And we really use that as our framework to identify nursing scope of practice. So Chapter 314 is the nursing chapter. There's a web link to it. You can go to our website and just kind of peruse through and see there's a ton of information. We'll highlight every statute that's kind of applicable to you as a nurse and then go forth with the regulations as well. The major statutes that you really need to know, the definitions is by far the most common one that I send out. It's 314.011, and that really defines the scope of practice for the LPN, the RN, and the APRN. Policies, the other one that I send a lot, 021, that says that we do things that we know are within our scope of practice. However, if we choose to do things that we are not educationally prepared and clinically competent to do so, that we are held accountable for doing things that we know are within our scope of practice. 031 really talks about those unlawful acts related to nursing, that we hold a license and that it's unlawful to pretend or to fraudulently say we are nurses. And so that really defines things that we shouldn't be doing. 041 and 051, for those of you out there who have nurse externs with you or new nurses who have passed their NCLEX or waiting to pass their NCLEX and they're working as RNAs or LPNAs, it kind of talks about the use of the RN applicant or the LPN applicant. 091, Chrissy will talk about this, and Jeff as well. What happens whenever we have any limitations or reprimands on our license. 155 talks about telehealth. Telehealth is a great example of the pyramid that I showed you, because telehealth has statutes, regulations, and advisory opinions, so that we break it down and really identify nurses' role using telehealth. And then 181 is determination of death by registered nurses. This is in the scope of practice for only RNs and APRNs. It is not within the scope for the LPN. We'll just talk about this briefly. There's a ton of information on these slides. The statutes themselves and the regulations have a lot of information that really give you guidance. The big things that I like to point out, 314.011 subsection 6 is the registered nurse, and then subsection 10 is the LPN. The biggest differences that you'll really see is just the underlying one on A, and it talks about how the LPN observes, cares for under the direction of the RN, APRN, PA, or physician or dentist. And so the RN they both are licensed, they both can practice autonomously, but they have to practice under the direction and guidance. If you're the LPN, the same way we look at all nurses have to have a provider's order before they can implement nursing interventions or administer medications. However, the LPN has to be directly under the supervision and guidance of an advanced provider or the RN. Other than that, your LPNs can work and administer medications the same way your RN can. Sometimes you'll see facilities have limitations on that, and that is different than saying that it's not within their scope of practice to administer a certain medication. Policy, this is my favorite one to talk about because we are all responsible and accountable for our individual decisions based upon our educational preparation and experience. At the end of the day, we want to make sure we're determining, is this act within my scope of practice? Yes. If it is within my scope of practice, am I educationally prepared and clinically competent to do it? There are a lot of things that I think I can do as an RN or even an APRN, but I don't think that I've been trained to do them. And so this is really using that critical judgment that just because I can do this within my scope of practice, am I clinically prepared to do this and understand my consequences should I choose to do something or delegate something that I know should not be done or delegated. Provisional licensure, for all of us that remember taking NCLEX and being applicants, this really just talks about what the supervision is required. It's the same way of having someone who is on orientation. We want to make sure that we are directly supervising them to make sure that they are doing tasks that are within our scope of practice. As an RN, you can supervise both an LPNA and an RNA, but as an LPN, you can only supervise that LPN applicant. We want to make sure that we are physically present and we are immediately available to these individuals who have not obtained full licensure in Kentucky. And then other than that, anything that is within my scope of practice, I'm going to teach this individual the same way I would my orientee on this is what we do as nurses, and then just have more oversight and guidance for the provisionally licensed nurse. Telehealth, this is again the one of 3 times we'll talk about telehealth today. Just this is the definition of telehealth, and that we are using any interactive audio, video, or any electronic media to deliver healthcare. As the nurse, we want to make sure that our patients have informed consent, that we want to make sure that they have the right individuals in the room with them, and that we are ensuring that they are confidential and that their HPI is protected, and that we aren't doing anything that would cause our patients to not feel that they are having confidential care using telehealth. Determination of death. Again, this is just saying that the RN who's employed by a healthcare facility may determine whether or not a patient is dead in accordance with the requirements of KRS 446.400, and that the nurse shall notify the attending physician or provider in accordance with their facility's policy. We can sign the provisional report of death as a registered nurse. And remember, this is not within the scope of practice of the LPN. Your facility may have very different guidance on this information that says it has to be 2 RNs or an RN and physician, or it can be physician only. That has nothing to do with the Board of Nursing. That is going to be organizational and facility-based policies. So do know that it is within your scope of practice as an RN. However, your facility may have different policies. Okay, so all of those are statutes. They are a little bit harder to interpret because they are not directed at, as the nurse trying to interpret what the statute says is my scope of practice. So we at the Kentucky Board of Nursing and all other boards take one step further, and they do Kentucky Administrative Regulations. And that is where we give more detailed directions that help implement the statute. So these now are the procedures. So you've got a policy that says, the RN can initiate an IV, or an LPN can initiate IV access. Now we have the procedure that's really going to give you the detailed step-by-step of do your 5 moments of hand hygiene, get your equipment ready, identify your patient, and give you a lot more guidance to implement the policies. This, like the KRS, has the full force and effect of law. So if this is something that you are doing unknowingly or intentionally breaking these laws, then you can have the KBN have reprimands on your license or do some investigation to see kind of how we've missed these, because these are, again, they hold that full force and effect of the law. KAR, kind of like KRS, has some numbers that go with it. So our regulations for the KBN are 201 KAR Chapter 20, which are nursing regulations, and then they go through 056 through 520. So there is a lot of information here. This as well will break down the education requirements for APRNs, the education requirements for LPNs and RNs and LCPMs. There's a lot of information in these regulations. That's why there's more of them. I will not talk about all of them because they're not always all applicable to what we do here in practice. The education one definitely has a lot more information just to identify how we regulate programs of nursing in Kentucky. The ones that we will talk about include 215, which are continuing education requirements. As a nurse, you all have all participated in your annual renewal, saying that you have just done some more education to ensure that we are always practicing to the highest level and continuing to grow as nurses in our education and training. 400 is always one that I use because we have questions about what can I delegate? Is this within the scope of practice for a nurse to delegate to an unlicensed individual? Is this something that I should be doing to delegate? We also will talk about the LPN infusion therapy scope of practice. We get a lot of questions about those as well. The nurse licensure compacts. All of you who live here in Kentucky and identify Kentucky as your primary state of residence are a part of the nurse licensure compact. And then our friend telehealth again has some more information in regulation. Continuing education. This is copied from our website. There's a lot of information that you can find out about continuing education. The big thing to know is that we renew every year by the end of October on Halloween. Everybody will have to have proof of 14 contact hours. A lot of individuals will do the 7 for having a nursing employment evaluation that is satisfactory, and then adding 7 more CE hours. You can do this by obtaining even national certification, going back to school for post-licensure, whether it's your master's or a doctoral program. You can serve as a preceptor. You can publish, you can present, you can do some research. So there are a lot of options to do competency-based education and experience. So don't be the individual that waits until October 29th and it falls on a weekend and you're very panicked about doing your continuing education. As a nurse, I think it's one of the best things to remind me that I still need to continue to grow and learn. So take that opportunity and realize that you can serve as a preceptor, and that really helps to your continuing education requirements. Delegation of nursing tasks. So this is the one that gets people in the most trouble or the most concerns, really, because it's identifying what is delegation and what is supervision, and how am I supposed to ensure that these tasks that I've delegated as the RN or LPN are being done, and am I showing up for my individuals who I'm delegating to ensure that they are competent and that they have follow-up on the things that I've delegated. So delegation means directing a competent person to perform a selected nursing activity or task in a selected situation under the nurse's supervision and pursuant to administrative regulations promulgated by the board in accordance with the provisions of KRS Chapter 13A. We also define supervision as the guidance by a qualified nurse for the accomplishment of a nursing task with periodic observation and evaluation of the performance of the task, including validation that the nursing task has been performed according to established standards of practice. The RN and LPN, and thus the APRN, can delegate to an unlicensed person. However, when we do delegate, we want to make sure that as the RN, we are not delegating those tasks that are outside of the LPN scope of practice to them. So as an RN, I can insert a PICC line. However, that is not within the scope of practice for an LPN. So even if it's the best LPN that I know and I'm going to train on myself, it is something not in their scope of practice and should never be delegated. So there is just some reminders that we want to make sure we're delegating appropriate tasks. And on the next slide, we'll really talk more about kind of the stability of patients and when we want to make sure that we are delegating. Task can be delegated directly or indirectly. An indirect delegation shall not alter the responsibility of the nurse for appropriately assigning and supervising an unlicensed person. So think of all the tasks that your UAP or your tech or your nursing assistant is doing throughout your day. Those tasks are actually indirectly delegated to them as part of their job descriptions, but it's nonetheless a nursing task. So we have UAPs that are out there obtaining vital signs and blood glucoses. I work with some really amazing techs who can do EKGs. And so you've got to think of all of these tasks that are being done as a job description. Those are still things the nurse should follow up on and supervise to make sure these tasks are being accomplished. Kind of like the 5 rights of nursing, there are safeguards that say, hey, is this the right thing that I should be delegating? We want to make sure that what are the needs of our patient? Is this a task that is reasonably something that all of you all on the call would delegate to a UAP as well? Is it something that can be competently and safely performed? Is it something that we do not require the UAP to independently use judgment or intervention? Is this something that the individual is even competent to do? Because again, just because it's something that can be delegated, is this something that the individual has been trained on, has been checked off on, and is it something within their job description? We also want to make sure that this is being done. And so we just assume that our colleagues are going to go check some vital signs and they're going to report back to us. How do they know what parameters to work to present back to the nurse and say, hey, I had a patient whose blood pressure was 175 over 110. Are there guidelines and parameters that you have individually as the nurse versus we all know that's a high blood pressure kind of thing, but that's still an assumption that that's a priority one that you want the UAP to return back to you and say, hey, this is what I got and this is what I'm kind of concerned about. And then you as the nurse can make decisions from that. The thing that I really have enjoyed in my nursing practice is just a small little huddle, whether it's with all of your nursing colleagues and your UAPs, or it's you assigned to 4, 5, 6 patients, and you have 1, maybe 2 different UAPs that are providing care with your patients. And so you just kind of sit and talk about the patients that you have, spend a couple minutes and say the patient in room 201 is a 2-day post-op patient. They should be getting up independently, but if they ask for help, you can help them. The patient over here in room 202, they're here for some hypertension. We've got it pretty well controlled, but let me know when their blood pressure is, anything over 140 over 90, please let me know. The other patient here is day 2 from having DKA, and we're checking their blood sugars now every 4 hours. Please let me know if it's, below 70 and above 140. And that way you just have really good dialogue and communication so that you're really ensuring that your tasks are appropriately delegated. You're having parameters that they want to follow up on and say, these are the things that I expect. How can I help you throughout your day as well? Because I know you're the only UAP here today. And so if it's easier for me to do this, let me know. And kind of just have really open communication with your colleagues. So that way we understand what we're delegating and our follow-up that's required by the RN or the LPN. The big thing that you've got to remember is that when we delegate the task on stable patients. We delegate the task to know that the individual I'm delegating to, this is either within their scope of practice or they're educationally prepared and clinically competent to do so. We also want to make sure that we are near and available to the individuals we delegate these tasks to. So that's, for example, I'm not going to delegate the first blood pressure from a patient who's back from PACU to my UAP. That's something that you absolutely can do as the RN because we're all busy. But that me personally, I want to make sure that my patient is stable coming back from PACU. I'm hopefully doing bedside handoff anyway. So I should be in there just checking a blood pressure, getting some vitals, making sure that they're relatively stable coming back from PACU. The patient who is more highly acute, that's always going to be the patient that the RN needs to care for rather than the LPN, and just kind of keep those things in mind as we delegate tasks to our colleagues. 201 KAR 2490 talks about the LPN's infusion therapy scope of practice. Prior to 2018, we had this really big document that said yeses and nos, and this is in your scope of practice, but this isn't in your scope of practice. And we kind of got rid of that. And so now we're really focusing on the fact that the LPN should be educationally prepared and clinically competent, and that they're performing these skills and tasks as they know that are within their scope, that they individually are prepared to do so, and that they have supervision requirements. As anybody, whether you're an LPN or RN or even advanced provider, when we have concerns or some things that we've never experienced, we're going to seek guidance and identify opportunities to learn or find assistance from colleagues who are more experienced or have just seen something that you haven't done. So don't be afraid that you're seeking guidance based upon a licensure level, rather than it's a team approach in nursing. So reach out to your colleagues and ask for help. But when you are the LPN, we've got to make sure that you have someone who is supervising you, who identifies, hey, this patient is stable, the rate of change is predictable, and it's not likely that this patient isn't going to do well. And then also we want to make sure that our supervisor, again, is immediately available if we are giving blood, if we think the patient has an ability or becomes unstable, or they are receiving any kind of dialysis, whether it's hemodialysis or peritoneal. So my favorite response from people is, well, anybody can become unstable. That is a very true statement. I, as a house supervisor, go to anywhere from 2 to 5 rapid responses a day. And so I get it. You can be on a med surg floor, you're doing just fine. And then out of nowhere, your patient just doesn't look well. There's some rate of change that you just can't identify. So you call for help. You get the ICU team in there and you kind of are looking and seeing what's going on with your patient. So that's very different. Patients can become unstable in theory anytime. However, if you're concerned and there are changes, then you reach out to your RN colleague or your charge nurse or even your manager, depending on where you work at, and say, hey, I've noticed a change in my patient. These are the concerns I have. Whether you use a tool such as a rapid response or whether you just reach out to someone that's saying, hey, like this patient probably needs a higher level of care, whether it's from the RN or it's moving from gen med to a PCU or TCU, or if that patient's really not doing well, they go to the ICU. So it's just really identifying if that patient is changing, I'm going to make sure and give them to a higher level of care. So this giant list has now shrunken to 12 things. And so it's kind of hard for some people to interpret because we're, as nurses, kind of like a yes or no response. And so there are 12 things that are absolutely not within the LPN scope of practice, and they are listed here. So we get a lot of gray area questions that say, well, I didn't really see it on this regulation, but does it mean I can't? If it is not listed here and you are educationally prepared and clinically competent, the answer is likely yes. But feel free again to send some questions to us and we'll send you this exact statute and regulation that say these are within your scope of practice. Again, if you are educationally prepared and clinically competent. The big questions that we see sometimes are about PICC line dressing changes. Those things are all not listed here. The only thing that really you can't do in regards is put it in. And that I think the other big question we get sometimes is, about doing some COVID therapy currently. So if you want to give any immunoglobulins or any investigation or definitely oncology medications, those things are not within your scope of practice. But other than that, there are a lot of things that you can do in regards to IV therapy. However, depending on where you work, that may have a different limitation on your scope of practice. So by Kentucky statutes and regulations, things are within your scope of practice, but your organization may choose to limit your scope of practice. And that is something that we at the Kentucky Board of Nursing have no control over. It's not within our purview to identify that, what happens in your organization. The Nurse Licensure Compact. We now have 39 states that have enacted the Nurse Licensure Compact, with several more states that have enacted it but have not implemented it fully. So what that means is if you identify Kentucky or even Indiana, or the states around us, as your primary state of residence, and you have elected at least in Indiana, selected that you want to pay extra for that, then you can work in any of these states. Here in Kentucky, as long as your license is in good standing, you can automatically you can automatically be enacted in the nurse licensure compact. So there's nothing else that you have to do with your Kentucky nursing license. If you move to another state, you have to change your address to kind of match where you're practicing at. If you take travel jobs, that's very different. But identifying your primary state of residence will give you access to the nurse licensure compact. The only thing that I really educate nurses on is that once I step foot into another state, I am responsible for identifying that state's Nurse Practice Act. So things that I do here in Kentucky might be very different in Indiana, definitely different from Texas. And so it is my responsibility to know that I'm using my Kentucky license to work in these other states. But just as anyone who comes into Kentucky, you follow the statutes and regulations that are for the state that you are currently working in. Last one is our friend telehealth again. So this is just now identifying even more information that says when we care for patients via telehealth, they have to be physically located in Kentucky because that's where our nursing license is, or be physically located in a state that is within the nurse licensure compact. So as you saw on the previous slide, Ohio has not yet implemented the nurse licensure compact. So if we are providing telehealth services to a patient who lives just across the border in Cincinnati, we cannot do that unless we hold an individual state license for the state of Ohio. So again, telehealth is based upon where a patient is physically located at. And so sometimes you'll see a patient that is physically in the office in Kentucky, but they live in Indiana. So if you prescribe it to them there in Kentucky, it's different than what happens in Indiana. So there is just definite more guidance on what means are for telehealth and where our patients are located versus where do we hold licensure. The rest of the presentation is really going to focus on those advisory opinion statements. And so this again does not hold that full force and effect of law. However, this is the guidance that we have vetted here at the Board of Nursing, everywhere from our consultants all the way up to the practice committee to giving us a full board decision on this is where we stand as a Board of Nursing in Kentucky. We say this is what's within our scope of practice. So advisory opinions, they are the board's responses to individual practice related inquiries as to what constitutes safe nursing practice. These are issued as guidelines to make sure that we are safe and that we are delivering good care that is effective to all the individuals who reside in Kentucky. Advisory opinion statements. So again, once we get a bunch of questions about a topic, we identify that, hey, this might be really good guidance to share with our constituents. So this is published for wide dissemination. Again, you can find the full web link to these on our website, and we'll talk about every single one of them, at least hitting the high points of them, and then really focusing on some that have the most frequently asked questions. Okay, when we talk about nursing responsibility, there are several of them that I really think kind of identify our foundation as a nurse, kind of what we need to do to make sure that we are practicing safely. So for all of our nurses out there, especially the LPNs, there is recommended course content for infusion therapy. Once we had changes in the curriculum for the LPNs, a lot of LPNs were taught infusion therapy. But a lot of individuals who've been practicing for 20 or 30 years didn't have the same education and training. So they have to either get checked off at their organization or attend an infusion therapy course to ensure that they are practicing up to date. Supervision and delegation, number 15, we will talk about that one in more detail because again, a lot of what we do is supervise and delegate. Advisory opinion 18 talks about using nursing students and nurse externs and how they kind of help support us nurses in the hospital and other organizations. 19 is the responsibility and accountability for nurses with patient care assignments. That's one that we'll talk more in detail about as well as 24, which is patient abandonment. 34, if anything, remember that we are always doing all of that we can to keep our patients' information confidential. And same way of social media, my 5-second speeches don't do it. I have no social media because that's how I prefer life. But those of you that are using social media, please use it wisely. Don't share your information. Don't share definitely about your really awful day at the hospital or your really awful patients or your really awful colleagues. Not that you want to only share good things, but be mindful about what we're saying about our patients and our colleagues and where we work at. Chrissy will talk definitely more in detail about social media gone wrong and how that can really affect your nursing career. AOS 41 is probably my favorite advisory opinion statement, and we'll talk about that towards the end. It kind of highlights all of the questions you need to ask yourself before you do a task that you kind of are like, man, I don't have enough information to do this, but my boss assigned this to me, that they tell me this is now within my scope of practice, or this is a physician order that I've never done this before. So making sure that we are doing things that we feel educationally prepared and clinically confident to do so. And then 42 is, again, our friend telehealth and gives us more guidance. Nursing scope of practice. So if you've got questions of, man, can I do this? Is this within my scope of practice? What do you think about this? These advisory opinion statements are really going to give you even more information. Number 2 focuses on gynecological cancer detection. Can I perform a pap smear as an RN? Practicing in the OR setting, what is my role as a circulator? What is my role in assisting? Wound assessment and staging. Can I insert an NG tube? Can I put the PEG tube back in? We've got implementation of patient care orders. 14 is a really big one. We'll talk about that one as well. What is my role in administering medications? Can I administer medications via epidural? Can I administer medications via an NG tube? And so that kind of gives you, again, more guidance on the different routes. PRN medications, talking about, can I remove a cast or can I do closed reduction of a fracture? That focuses more for the APRN. Can I insert a central or arterial line? Can I draw blood from them? What is my LPN scope of practice in 27? That's another really big one. We just updated that one last month. And so that, again, gives you more guidance on what my scope of practice is for the colleagues that are LPNs. Cardiopulmonary respiratory, we talk more about, can I remove the arterial venous devices? What about compression devices? What is my role as a nurse when I'm doing procedural sedation and analgesia? Can I remove a chest tube? 35 is another popular one. I think we could have a whole presentation on cosmetic and dermatologic procedures. If you are out there working in med spas or giving Botox, please read over this advisory opinion statement, because I find that a lot of nurses are doing more things that are not within their scope of practice. And so just remember, as an RN or LPN, you always have to have a provider, have a patient assessment and an intervention treatment plan, and do evaluation. So as an RN, I cannot have a Botox party and invite individuals over and assess them and administer medications. It is outside of your scope of practice as an RN. APRN Chem can absolutely do that. I can assess them, I can prescribe them, and I can implement those procedures. So just kind of read over some of these things if you are out there practicing, because they will give you more guidance. And nursing roles. So these are all, not all, but a lot of the settings that we work in as nurses, and what can we do? So intraspinal, if I'm working in the OR, what can I help and do when it comes to anesthesia? Can I staple and suture? Can I put on topical adhesives? I've been a labor and delivery nurse. I did it for 10 years. And so what can I do in prenatal and intrapartum care? Is that different and different requirements of me in that setting, or in psych mental health? Or if I work in cath lab, what can I do in regards to cardiac procedures? We have one for our dialysis technicians and the nurses who work in dialysis care. Can I provide private duty at home? What does that mean for me as a nurse to do at-home care for individuals? Can I do ACLS? Can I help provide assistance with ambulances? I work in endo. What can I do in endoscopic procedures? School nurses, and again, can I delegate tasks to paramedics who are in the hospital? And so we've got some real guidance for you as nurses and where you work at in settings, and we'll help you determine scope of practice. Okay, to break them all down, so we'll spend the last 8 or 9 slides really talking about the very different AOSs that are going to affect you. Implementation of patient care orders. So at the end of the day, there are policies and procedures that you follow, your providers are going to follow on really determining, like, how do we identify patient providers? And are we ensuring that they have a physician or an APRN or PA who is appropriate for them? So identifying that, hey, this patient was admitted to someone, they have consulting physicians. Is this someone that is appropriately ordering and seeing our patients? We want to make sure that we as nurses review and verify orders. For those of us that use Epic, it is a wonderful system because it pops up real big and pretty on the front page for me that says I have new orders. Whether you're using paper charting or have different systems, hopefully there's some safeguard to help you as the nurse identify, hey, I've got some new orders, or your provider tells you, hey, I looked at this patient's labs and I ordered some potassium because they were hypokalemic. So make sure we have opportunities to review orders as they are put in. Your facility is probably going to have some guidance for you on using verbal orders or telephone orders. The Joint Commission has some guidance that we have put into this advisory opinion statement, even on using text. So texting via phones is not something that is approved with the Joint Commission. The organization I work for uses Tiger Text, and so we can send secure messages that do include HPI. So make sure that we are not sharing information inadvertently and that we are using the correct policy and procedures that guide how we communicate with our providers. Receipt of orders through an intermediary. So as an OB nurse, I many times would be in a C-section and my provider's phone is ringing and I answer it and they've got questions or they need some Zofran for a patient who's got some nausea. I absolutely can talk with my provider, get a verbal order and give that through them. The nurse who receives that order needs to verify and follow up with that physician that was correct order. Just say, hey, you were in the OR earlier. I had called you about this patient and gave them this medication. They've improved, they've not improved, but you can give those orders through the intermediary. As the nurse, we always want to make sure that we question appropriateness, that we will refuse anything that we don't think is correct, or that we're just kind of confused, was this ordered on the right patient? Because we can take orders from physicians, dentists, APRNs, PAs. We have standing orders, protocols. The pharmacist can change the order because they're on vancomycin. We want to just make sure that we're doing all the things as we should. There is a really good section that talks about standing orders versus protocols. Standing orders require no provider to put those orders in. So there's just a standing order set for someone who's admitted to the emergency department. Protocols, there may be a hypertensive emergency protocol that our providers need to put in to make sure that they are selecting the right options to help treat some hypertension. And so we want to make sure that we identify what we can do to put in as the nurse without a provider's order, because it's a standing order that's been vetted by your organization or a protocol that a provider wants to put in. And then lastly, it is not within your scope of practice as an RN or LPN to complete written prescriptions. We do not have prescription authority as RNs or LPNs. So my provider, say, handed me a handwritten prescription that's for just some ibuprofen, not even a narcotic, but they forgot to circle the number of refills, or they forgot to say that it's TID versus BID, and I wanted to scribble that in real fast. It is something that you absolutely cannot do as an RN or LPN. You need to call your provider and say, hey, you completely missed this little section here. I need you to come back in. Can you send this electronically? So just know that you cannot complete that prescription because you do not have prescriptive authority. Also, we'll talk about delegation and supervision. So again, it's a very big component of what we do here as nurses. That's why you see it in statute and regulation and in an advisory opinion statement. I think this is mostly just kind of what we've talked about, making sure I'm delegating the right task to the right person under the right circumstances. I give the right direction and communication, and I am supervising and evaluating that these tasks were completed. We want to make sure that we are only delegating tasks after a nursing assessment is made and that this task is appropriate. So again, I'm getting a report from my nurse from night shift, and she or he is telling me that the patient had a little bit of high blood pressure overnight, that they were going in and checking the blood pressures themselves manually. I'm going to say, oh, well, let me keep that in my brain. So when I talk to my UAP, I'm going to say, hey, this patient has been more unstable throughout the night. So I'm going to check these vitals and make sure that they're okay. However, throughout the day, if they become more normotensive and I don't feel that they are as unstable, will you help me check their blood pressures every 2 hours later? Okay, so making sure that I'm assessing and that it's appropriate to delegate tasks to my UAP. We also want to make sure that we are not doing anything to jeopardize the client's welfare. So again, is this something that we feel good and confident about that we are delegating tasks? Some of these tasks include vital signs, obtaining glucose, any really ADL assistance or self-care task. We can have them assist with feeding. There are some organizations that will even say that they can do stoma site care, they can help with feeding tubes. It kind of is just a very big spectrum of what your organization allows to be delegated. So again, make sure and you refer back to your policies and procedures of your organization to ensure these tasks can be delegated. Patient care assignments. One of the number one questions we get at KBN is why are there no nurse-patient ratios? And so that is something that is not regulated by the Kentucky Board of Nursing. However, the Cabinet for Health and Family Services does have some guidance, but nowhere will you find that says an ICU nurse can care for one patient or two patients and that your med-surg nurse can take care of 5 or 6 patients. The American Nurses Association may have recommendations, or those specialty areas may have guidance. However, that is not regulated by the Board of Nursing. However, when we do patient care assignments, we are hoping that your charge nurses and your administrators are really looking at to see who's working, what are my qualifications, what patient care needs are there, and really just ensuring that we are providing safe care as best as we can. I can tell you as a house supervisor, there are some days that I cringe when we have to have 6 patient ratios of med-surg and our charge nurses are in staffing because we just don't have enough nurses. So I can feel for the concerns of having patient ratios. However, we really want to make sure that we are protecting our patients and our staff as best as we can to ensure that we have good working ratios. Whenever we do this, we want to make sure that if we do have to send a nurse to another unit. So I love to pick up as a task nurse. You can put me literally anywhere in the hospital and I'm going to go help however I can, because I do firmly believe as a nurse, we all have a very core foundation and knowledge and competence. However, I understand that if you've only worked OB, caring for an elderly male patient is probably very different than what you've ever known. However, we all know how to check blood sugars. We all know how to check blood pressures and vital signs. We can assist with ADLs. And so when we are reassigned to these specialty areas, we want to make sure that we are delegating certain tasks to these nurses that they are competent to do. What are our expectations when we send them to different units, and that they have a buddy, whether it's another RN there, whether it's the charge nurse who is educationally prepared and clinically competent within those specific areas to act as a resource. So if we have concerns, someone is there to help us. At the end of the day, as a nurse, if you feel that you are unable to provide safe and competent care due to either the number of patients assigned, due to your own experience and limited competency, you as the nurse are obligated to refuse to accept the assignment and inform your supervisors. you should there begin to collaborate with your supervising personnel to assist in performance of acts. So if you're like, man, I've never given this medication in my life, and it's going to require me to be in the room for an hour, and I just don't even know what to look for. Hey, nursing supervisor, can you help me through this? Can you walk me through the steps? Can I watch you do this one time and kind of really get a feel for it? And then when this med is due again in 4 hours, I'm going to feel pretty confident to do it myself. We want to make sure that you ask for more educational and training, more supervised clinical practice, especially if this is something that is going to be new within your job description. If you as the nurse believe that this assignment is unsafe, and again, you are not educationally prepared or clinically competent, but you still perform this task or you still care for these patients, you assume the potential liability that may occur as a result of this assignment. Others may be also concurrently held responsible and accountable and liable for your actions. However, the 021 statute really defines it as the nurse. If we are doing things that we know are outside of our scope of practice or that we are unsafely doing, that we ultimately hold that responsibility for the decisions that we made. This leads into AOS 24, patient abandonment. And so what we really try to focus on when we talk about unsafe ratios or unsafe patient care assignments, or just really trying to figure out how we can refuse assignments without being performing abandonment of our patients, because at the end of the day, we have a professional and ethical obligation to provide care for our patients, and that we can only withdraw care when we know there is another nurse to take care of our patients. And so I will be very clear again, if we make the right steps to say, hey, I feel unsafe for this patient. Hey, can I have more assistance? Hey, I need some more education and training. And we are trying to switch assignments and say, hey, Myra, this patient that I have, I think that is not safe for me to care for. Do you mind switching a patient with me? I'll take care of this other patient of yours. And then as you go provide care for this patient, can you teach me some things about this? And so that I can grow as a nurse. That is doing our due diligence to assure that our patients truly have someone to provide care for them. Nurses who have accepted a patient assignment may only leave after we communicate the need with the supervisor and we have exhausted all reasonable and prudent efforts to place patient care in another nurse's care. Abandonment only occurs when a nurse is voluntarily removing themselves from the care delivery setting without giving any notice and without making arrangements for another qualified person to assume patient care responsibility. Okay, so we've done our due diligence. We've tried. You can see everything from a nurse who has an emergency at home and they need to leave. And so the charge nurse is going to take a patient for you. You're going to reassign your patient assignments. Okay, so that does happen sometimes where we have a nurse go home sick. And so how do we kind of change the patient assignment so that that nurse can leave and not have concerns about abandoning their patients? We have, again, nurses who feel that this patient is not safe for them or that they need a higher level of care. So they take report, but then they start talking to their charge nurse about it. And we call the provider and maybe we get an upgrade of care and that patient goes to a higher level of care, but maybe not. You as a newer nurse or you as a nurse who just doesn't feel confident, even if you've got 10 or 15 years experience, we want to always reach out to our charge nurses and say, hey, like I'm really overwhelmed by this patient. Can you help me? Can you find me a different patient? Can you teach me something new? Like those are the correct steps to identify that we feel unsafe about assignments or unsafe about patient acuity. We again follow KRS 314.021 that we are doing things that we know are safe and effective and that we are using good judgment when we provide care to patients. There are lots of things that we do not have within our purview at the Kentucky Board of Nursing. There are many employment issues that do not rise to the level of patient abandonment. So you may hear that you're abandoning your patients. However, again, if you talk to a supervisor and you've exhausted all reasonable and prudent efforts to get someone else to care for your patients, and that you've tried to switch assignments to do things like that, does not rise to patient abandonment. They are not within our jurisdiction. However, your employer may determine that that is not satisfactory for their policies, and that you decide to no call, no show for work the next day because you're overwhelmed, or they're mandating you over tonight for now 16 hours, or you want to quit tomorrow and not put in a 2-week notice. Those are things that are employer related concerns that are not within the purview of the Kentucky Board of Nursing. So there is nothing that we provide guidance to you there. You need to follow up with your policy and procedures of your organization on how late it is to call in the morning if you're not going to make it, or if you're getting mandated over. There are guidelines that you will see from the American Nurses Association that really say what are safe working hours and how to be a good employee. However, those things are not within our purview here at KBA. Components of LPN practice. So again, the big thing that you need to know of working with LPN colleagues is that they are licensed individuals. They have gone through training and they have adequate education and competency to perform tasks. The thing that you need to know about your LPN colleagues is that we as the RN need to make sure that the patient is stable, that the rate of change is predictable and it is small, and that we want to make sure that they don't have complex nursing tasks or more complex healthcare that may have a higher risk to have change in their acuity levels. We want to ensure that our LPNs are educationally prepared and clinically competent, as in these are some tasks that happen on your unit versus if I work on an ortho unit. Has an LPN who I know is a great LPN, have they ever worked on an ortho unit? Do they understand traction and how we move our patients post knee surgery? And so just ensuring again that we have the right patients for the LPN to care for, and that as the RN, we are directing and supervising and ensuring that our patients are safe and that our LPNs are supported. There is new guidance that just is going to the board next week. I think our board meeting is next week, that will go to the board this month, and that will have even more guidance for our LPN colleagues out there so that we can help support LPNs. Because at the end of the day, an LPN is going to be practicing by an RN, and they're both going to provide great care. It's just knowing the limitations of the LPN's education and training sometimes does cause us to reroute our patient assignments and ensure that they are supported. Maintaining confidentiality. This is something that hopefully you've heard all throughout your nursing career, and that you ensure that we are really practicing to the highest level from the ANA Code of Ethics, that it is our duty to maintain patient confidentiality, both personal and clinical, in the work setting and in all off-duty venues. So again, it is never okay to say, oh, that patient in room 2 today was the worst patient, and really talk about how bad our hospital is or how annoying our colleagues are. We want to make sure that we do everything to protect our patients and our organizations, and that we aren't sharing information inadvertently. We want to make sure that we only disclose information that is need to know. That implies that, hey, the dietitian is coming around to talk to the patient about post-surgery ways to increase protein to help healing, ways that they can work to manage their diabetes. So those are conversations that the dietitian will know that, hey, this patient is going to surgery and they have concerns. However, we don't really need to be sharing more pertinent information, such as all the medications they're taking or the in-depths of their treatment plans. They have a more limited need to know basis that they're helping healing and dietary needs of the patient. However, they don't have all of the concerns that you would have as the nurse. Or if the environmental services is coming in to clean the room, I'm going to be kind of mindful of the conversations that I have about my patient and not necessarily disclose their sexual health history because someone else is in the room. So just being mindful that it is not always a right to know every detail about all of the patients on your unit. It's a need to know basis, so that if I take a lunch break and my colleagues know that my pregnant patient patient is HIV or Hep C positive and they go into the room because there's an imminent delivery. Those things I feel are need to know to share who's covering my patients. However, I don't need to tell every single person on the unit about my patient and her herpes. So again, be mindful about what we share about our patients and then where we're sharing them, because there are ears everywhere in the hospital and you think you're just talking at the desk and people can hear you. So really be mindful of that. Social media as well. Be mindful of what you share. And then what happens if we do breach confidentiality? You can find that in 091. Okay, so you've heard me talk all of this time about all the things that you should be doing or not be doing, or really didn't answer any of your questions. Either way, we really have this great determination now that says, hey, Kim, you answered none of my questions. And I want to know, is it within my scope of practice to do microblading? Is it within my scope of practice to assist in an endoscopic procedure? I don't know the answer to all those things. So if you can't find the answer, or you're confused about the website, or you told me to go to this link and I meant to go to an advisory opinion and not the statute, and you just can't find an answer, this scope of determination of guidelines decision tree is going to be your key factor in saying, should I be actually doing this or not? And so not all nursing tasks and functions can be a yes or no. And I, as a person who lives in the black and white, sometimes I need to know yes or no, but it's not always there. And if you've ever emailed me or any of my colleagues, we very rarely give a yes or no. We kind of give this guidance on here's the information. And we say, if you are educationally prepared and clinically competent, this may be within your scope of practice. So do know that there is some guidance for you. We'll kind of break it down. We cannot say yes or no, even if it was possible, because practice is always changing. We, as the consultants here, really do some evidence-based research. So every 3 to 4 years, we work to update our advisory opinion statement so that we are not limiting our scope of practice and have questions. And so we'll walk through this together. It's kind of small, but it is on our website. So feel free to just kind of look at this. It's a nice little algorithm that if you say yes to everything, go forth and conquer and do the task that you are assigned. So we'll focus on, is it in my scope of practice to do microblading? Because that was the last question that I saw we answered. And so the question is, does the Kentucky Nurse Practice Act or administrative regulations or advisory opinion statements say that I can do this? So if I'm the RN or APRN, we actually can find it in there and it says, oh, well, I can administer medications and I can perform treatments that are assigned by a provider. So yes, I'm going to move on. Is performing this act considered evidence-based nursing, and is this in current literature? Well, there's a lot of research out there that says yes, a lot of research that says anybody can do this, and there's a lot of research that says sure. So I'm going to go with yes. Are there any facility or organizational policies that support this intervention? If I'm working in a hospital, no, I'm not going to be doing microblading in a hospital. But are there provider offices and salons and spas that say this is in your scope of practice? Yes. Do I have the necessary education and clinical competence? Well, I took a class on this and I got a certificate, and I've done things that are above my normal core nursing education. Yes, I've done additional training. I've completed this in a clinical that I did this on 10 patients. Do I think you probably need more? Maybe, but you do have some education and clinical experience. And then do I, hold on, let me see, I'm trying to read it. Do I have the knowledge to do this task? And am I sure that I have documented information? Yes, I went to this class, so I feel good about doing it. Is this considered an accepted standard of care that would be provided in similar settings, so that if a nurse, any of you on this meeting said, yeah, I would do that, then I'm doing something that's within a standard of care. I think that by performing microblading, whether it's what you want to do or not, I think that it's a standard of care for an RN or an APRN to do. Are you prepared and accountable for any outcomes that happen based upon what your actions are? And so, yes, I feel good. I know that's not against the law. My organization says I can do this. I attended an extra training class that was above my nursing education. I've done this on 10 different patients before, and I feel pretty good about doing this now. I think that this is something that all nurses like me would do with the same education and training. And then if something bad goes wrong and my patients have an adverse reaction, I still feel okay about performing this procedure. Then go forth and conquer and perform these tasks because you have hit all the check marks that say there's nothing in law that says I can't. My organization says I can. I'm educationally prepared and clinically competent, and ultimately I will accept any responsibilities for my actions. And so again, if I can say yes to all these things, then please do it. However, hey, I've never put in a catheter on a female patient. I did it like in nursing school, but I've just never done it. And so you can say yes to all of those things, but do you again feel clinically competent and educationally prepared to be doing these tasks? And it can be something as simple as putting in that Foley catheter of, hey, I've never actually done this on a human being, and pause and get someone else to do it with you. It's that easy to just be a little humble and say, I've never done this before. And it might sound silly because I've been a nurse for 4 years and I've never done this. Can someone go with me? And that's those pausing moments that we want to ensure that we are doing things, yes, that are within our scope of practice. However, do I have the experience and the training to really know what I'm doing? And so never be afraid to ask a friend for help. Competency. So again, if you didn't hear me say it 20 times, I did not do my job. We are individually held responsible and accountable for being educationally prepared and clinically competent for any act that we perform. Being a nurse requires us to use knowledge and skills in so many ways. We use it as critical thinkers, effective communicators, when we perform any interventions, and our caring behaviors. Those identify who we are as nurses. And so we want to make sure that we use all of these to really care for our patients in a way that is up to a standard and that we are keeping them safe. More information. The big things that I want you really to remember are KRS 314.011, 6 and 10, identify RN and LPN scope of practice. KRS 314.021 is the policy. And so again, that says if you are educationally prepared and clinically competent, you can do these tasks. Advisory opinion statement 41, that is the decision tree we really talked about that says, should I be doing these things even though it's within my scope of practice? Am I, again, educationally prepared and clinically competent? And then wrote a couple articles last summer about frequently asked questions for our RNs and LPNs. You can find those on our website as well. And they kind of break down even more questions that we have. We are also working for our website update to put some of these questions online so that if you have a question about patient abandonment, it's already been answered, and that it can be there for you on our website, or having more guidance about cosmetic procedures, because that's always a popular one as well. So just giving you more information for your scope of practice as a nurse. And then finally, you can reach out to myself or my colleague Tina, who do a lot of information focused on practice. My colleague Myra and my other one, Sarah, are APRNs as well. So they can answer questions for the advanced provider as well. And then that is all I have. Thank you all. We will do questions at the end.
Thank you, ma'am. You will need to go ahead and click on the participants and make me the host one more time. Sorry about that.
Okay, should be done, Eric.
Thank you, ma'am. All right, I will now be making Chrissy the host.
Okay. According to the schedule, we are going to take a break now, and we will start back up at 10:30. So everyone come back at 10:30 and we'll start back up then. We're going to take a little break. Thank you. Good. I am Chrissy Blazer. I am an investigator, staff to the board. For the next little bit, we're going to talk about the investigation and disciplinary process and violations that can lead to discipline. I have been a nurse 25 years. I have been with the board going on almost 10 years. My history in nursing is I've worked med surg, psychiatric, and regulation in nursing. And I've been with the state 20 years. So I'm going to go ahead and screen share now, get my presentation started. Okay, so we're going to go over the investigation branch and disciplinary process. We'll hold all questions to the end, so just take note of any questions that you might have as I present. We license over 99,000 RNs, APRNs, and LPNs. We also have jurisdiction over the licensed certified professional midwives and dialysis technicians. We enter anywhere between, in our branch, in the investigation branch, anywhere between 1,600 and around 1,900 complaints a year. Within our branch, we have a supervisor. We have 7 investigators and an APRN investigator. We have 2 program coordinators and an administrative specialist that all help to support our branch. In the compliance branch, which my peer Melissa is going to speak about in a little while, there's a branch manager. There is 5 case managers and an APRN investigator. They have a program coordinator and an administrative specialist. Within our legal services branch, we have an attorney supervisor, a staff attorney, a legal assistant, and a paralegal. At any given point in time in our investigation branch, we have approximately 800 cases under investigation. The purpose of disciplinary action is to protect and safeguard the health and safety of the public first and foremost, but it's also to maintain the integrity of the nursing profession. And by doing so, every year the Gallup polls are done, and typically nursing is ranked the #1 most trusted profession. And so by doing and through disciplinary action, we help maintain that we are typically the #1 trusted most profession out there. And that helps maintain that through the public's vision of us. Kentucky is a mandatory reporting jurisdiction, and that is by law, KRS 314.031. And that means that anyone that suspects that a nurse has violated any nursing law should report that to the Board of Nursing. So any nurse themselves can report, they can self-report. Employers of nursing and just anyone in the public having knowledge of a violation should report to the Board of Nursing. The types of things that we want reported to the board are fraud or deceit in attempting to procure a license, continuing education violations, felonies and misdemeanor convictions. And the reason those are real important is because a lot of felonies and misdemeanors involve alcohol, drugs, deceit, fraud, breach of trust, physical harm or endangerment to others, falsification of records, or dishonesty. So those misdemeanors and felonies are very important for the board to know about. Negligently or willfully acting in a manner inconsistent with the practice of nursing. Lots of things can fall under that. Being unfit or incompetent to practice nursing safely. Abusing controlled substances, prescription medications, illegal substances, or alcohol. Misusing or misappropriating drugs placed in the custody of the nurse for administration, also known as diversion. Falsifying or in a negligent manner making incorrect entries or failing to make essential entries. Used or possessed a Scheduled I controlled substance. Has used or been impaired as a consequence of the use of drugs or alcohol while practicing as a nurse. You have violated the confidentiality of information or knowledge concerning any patient except as authorized by law. And there's other violations of KRS chapter 313, which I'll go into, regarding other licenses, criminal convictions, and then other violations of the regulation 201, chapter 20 regarding specific prescribing violations for APRNs. When we specifically talk about misdemeanor and felony convictions, we most often receive that information from applicants themselves. Typically for initial licensure, on renewal applications, reinstatement applications, and endorsement applications. We also receive that information from criminal courts. Police officers will call us, other administrative enforcement agencies, the public in general, and employers. It's not uncommon for us to get complaints from ex-boyfriends, ex-girlfriends, ex-spouses saying, you know, someone was locked up over the weekend for a DUI or possession of marijuana. That is not uncommon for us to get those types of complaints into the board office. You must report all misdemeanor and felony convictions except minor traffic related misdemeanors, speeding tickets, that sort of thing. No insurance does not have to be reported to the board. Driving under the influence must be reported to the board. All convictions must be reported to the board within 90 days of a final conviction. The documentation that the board needs is they need a certified or attested copy of that final court record and a detailed letter of explanation that led to that conviction, circumstances on exactly what led to that conviction. The board has a very specific definition of what a criminal conviction means. It means an unvalidated adjudication of guilt, pleading no contest or nolo contendere, or entering an Alford plea, entering a guilty plea pursuant to a pretrial diversion order, regardless of whether the penalty is rebated, suspended, or probated. And while that's very important, is because a lot of nurses, if they have diverted controlled substances for a facility and they are a first-time offender, in the legal world, a lot of times they will enter what's called a pre-trial diversion order. And a lot of times their attorneys will tell them, and it's true, if they complete that pre-trial diversion order with the criminal courts, it goes away as if it's not a conviction. But our definition for the board is that it is a conviction, and we need to know about that because we need to know if a nurse has got a pre-trial diversion order for such things as theft of controlled substances, because that's very important for the board to know that they have been convicted of theft of controlled substances, because it is our job to protect the public. If you have any questions about any reporting or anything regarding what needs to be reporting regarding a criminal conviction, you can go to our website at kbn.ky.gov and go to the reporting criminal conviction brochure and review that. Now, when it comes to action in another state on a professional license or a credential, this is also by law per 314.108. This must be reported on initial application for licensees and within 30 days for current licensees. Must be submitted the documentation that is needed. We must have a certified copy of that disciplinary action, as well as a detailed letter of explanation in regards to the disciplinary action and what led to that. Typically, say you are working in Tennessee on your privilege to practice, and you get disciplined in Tennessee because you failed to document medications while you were working there. They will give you an order, and You must report that action for whatever they give you. If they give you a reprimand, if they give you any kind of discipline in Tennessee, then that must be reported to Kentucky within 30 days so that Kentucky is well aware of what happened, as well as a letter explaining how those documentation errors occurred, and so that it can be reviewed by our board. Now we're going to talk about some APRN licensure commandments when it comes to prescribing. And this is really important. You want to ensure that you have on file with the board notification of your Kappa CS and Kappa NS. The first 4 years of practice, you need to report any changes with either one of those within the first 30 days. You need to have all Kentucky DEA registrations on file. You must be registered with Casper and have a master account. You need to provide a copy of the Casper verification certificate. You must query Casper for the 12-month period immediately preceding the request for available data on any patient and document that data in the patient's record. During treatment, you must review Casper no less than once every 3 months for the 12-month period. And you need to review a reverse Casper on yourself as a prescriber every 6 months for the preceding 6-month period, and take any needed corrective action that needs to happen on that Casper. You need to have your national certification, a current practice address, a current mailing address, and a current email on file. You cannot practice or use the title APRN if your license has been voided or is not active. And all documents now are uploaded via the KBN APRN portal. When it comes to prescribing violations, this is where we'll see prescribing violations. People are not always aware of their limits. So Schedule 2s, you can only give a 3-day supply with no refills. There are some exceptions to that. And that is with psychostimulants, and those are prescribed by psychiatric mental health nurse practitioners, and they can give a 30-day with no refills. Hydrocodone is treated as if it's still a Schedule 3 in regards to quantity. Hydrocodone combination products, there's a 3-day supply for acute pain only. Chronic pain, 30 days, no refills with substantiating documentation. Schedule 3s are a 30-day supply with no refills, and all other drugs are a 6-month supply. All prescriptions must be dated on the date the prescription is signed or authorized. It is unlawful to issue multiple duplicate prescriptions on the same date with the words "do not refill until," where the combined supply exceeds the APRN supply limitation as stated previously. You must comply with the scope and standards of all prescribing. You need to obtain and review the patient's Casper report ID every 3 months and document that in the patient's chart. You want to always update that record and treatment plan as appropriate when it comes to the prescribing of those controlled substances. You want to ensure your medical records and exam and history are correlating with the prescribing of those controlled substances, that you have a treatment plan and diagnostic test and screening tools that are correlating with the prescribing of those controlled substances. You want to advise the patient and obtain consent and review the risk and benefits and the use of controlled substances. You want to document the discussion and obtain written consent, and you want to have an exit strategy for coming off of those controlled substances. You want to document the foregoing actions in the patient chart, as well as the following information for every drug: the date it was prescribed, the type, the dosage, and the quantity. When it comes to opioid prescribing, you need to run a reverse Casper and pull 10 of your own charts from opioid patients. Ask yourself the following questions while reviewing those charts. For opioid naive patients, were all non-opioid and non-pharmacological interventions tried? Have you done physical therapy, occupational therapy, NSAIDs? For patients on opioids, have the treatment reasons been validated? Do you have labs? Do you have imaging, MRIs, CAT scans, x-rays, other records? Ensure you have an updated treatment plan and review annually is the best practice. Ensure you have appropriate urine drug screens to include random screens to ensure what you're prescribing is what is in that urine drug screen. Ensure that you have a current reviewed and signed Casper report number, even if it's done by a delegate. Ensure that they are assessed in person, that you have a controlled substance contract and it's reviewed yearly. Ensure that they have that the pain is rated at every visit. There's a safe level of the morphine milligram equivalent. CDC recommends avoiding doses at 50 or above. And that if it is at 50 or above, you need to educate on respiratory depression and prescribe Narcan to those patients. And this information is now on the Casper report. You want to educate on avoid combining benzos, alcohol, and other sedative drugs when on controlled substances. If shared audit charts with a collaborator or a peer within the same specialty, do they agree with your plan of care? And remember, your plan should always be patient-centered care. The board does have jurisdiction over imposters. Possible criminal charges can be pursued. 48 persons to date have been issued cease and desist letters. We do see a rise in this, during crisis times. Unlicensed persons will pose as a nurse. Nurses will alter their credentials to practice as another position, LPNs as RNs, RNs as APRNs. Individuals try to gain fraudulent credentials. A nurse will steal another nurse's identity. And right now I do know our credentials branch has been real astute. There's been some fraudulent transcripts coming out of Florida recently. And so there have been individuals trying to gain fraudulent credentials recently. And so we do watch for that very, very astutely here at the board. When you have a suspicion that a nurse has violated nursing law, we always want someone to file a complaint. And so we do that by asking individuals to go to our website and file a complaint online. We have online consumer facility self-report complaint forms. And we ask that the complainant complete as much information as possible on that form. We want as much identifying information on the nurse as possible, their license number, social security number, date of birth. We want information so we can contact that complainant back for clarifying information. We have a lot of Smiths in the state of Kentucky, so we need to be able to narrow down who that individual is. Complaints come in from all different avenues. We get them from healthcare facilities, coworkers, doctors, patients and family, nurses even self-report to us on convictions, such things as when they relapse. And my friend and peer Melissa will talk about this. When they relapse from substance use disorders, we get anonymous complaints in. We do internal and administrative complaints for such things as not completing continuing education, because we do audits every year. So such things as that, or if we find out that a nurse has had a conviction and it's not been reported, we will do internal complaints about that. And so the board does do complaints that can send out to the nurse. We can also refer complaints, and complaints get referred into us from the Office of Attorney General, Cabinet for Health and Family Services, Office of the Inspector General, other boards of nursing, other regulatory boards like the Board of Pharmacy, law enforcement agencies, and drug enforcement agency. As part of the complaint process, the board does allow for subpoena power. So typically, the board will subpoena medical records, personnel files, whatever is needed to go forth with the investigation. The board will subpoena lots of records in order to be able to complete an investigation. We do criminal background checks for every nurse that we have under investigation. We do prescription monitoring reports on nurses that we have under investigation. We have the ability to run Kentucky, Indiana, Ohio, Tennessee, and West Virginia. So we have the ability to run for surrounding states around us. The board does have the authority to order nurses to undergo physical, mental health, and substance use disorders as part of the investigation process. The nurses do pay for those themselves. Per law, KRS 314.085 grants authority to the board to order an evaluation based upon reasonable cause that the nurse is unable to practice with reasonable skill and safety or has abused alcohol or drugs. If a nurse is ordered to undergo an evaluation and they fail to comply with a board order evaluation, then it will result in an immediate temporary suspension of the licensees of their license. So the board also can suspend a nurse's license, not only for failing to obtain a board order evaluation, but for submitting a bad check or insufficient electronic payment to the board, but also for failing to pay Kentucky child support, for being a delinquent taxpayer. And also this one involves heightened scrutiny, but in order to protect the public. And so when that happens, that involves several people agreeing that the nurse is a continued threat to the public if they continue to practice. And so the board does have the ability to issue that. When it comes to nurse licensure compact and complaints, if there's enough evidence to indicate an immediate threat to the public, we can issue an immediate temporary suspension on a nurse's license or privilege to practice in Kentucky. So if we have someone here, say from Tennessee, working in Kentucky on their privilege to practice, and something occurs in Kentucky that we feel that they are a continued immediate threat if they continue to practice in Kentucky, then we will do an immediate temporary suspension on their privilege to practice in Kentucky. Factual findings in disciplinary cases are shared among compact cases. And the nurse licensure compact does allow for subpoena power among compact states. So it does allow for the two states to share subpoena power and information. If you're under a disciplinary order and you want to work in a remote state, you must make application to the remote state and be issued a single state license. So if you're in Kentucky and you have a disciplinary order, okay, and you want to go work in Tennessee, then you must make application to Tennessee and be issued a single state license to work there. Kentucky provides all of our investigative and disciplinary information to nurses for access to all state boards of nursing and employers. Disciplinary action on a license or a privilege may be accessed on our webpage and licensure validation at kbn.ky.gov. The role of each investigator is we are to conduct investigations and gather information. We are a fact finder. We attempt to bring cases through resolution and through settlement, either through a consent decree or an agreed order or through an administrative hearing. Our general counsel, Jeff Prather, is going to talk about the administrative hearing process in much more detail. And we do present cases to the board for final disposition. All information per the regulation, all preliminary information is treated as confidential during the investigation and shall not be disclosed to the board members or to the public. The board shall make available to the public the fact that an investigation is pending. The only exception is to reporting to law enforcement. A nurse can be charged with failing to cooperate with the board. This is per the statute. A licensee, a credentialed holder, a privileged holder, or an applicant who is the subject of an investigation by or on behalf of the board shall fully cooperate with the investigation, including responding to a complaint or a lawful request for information in a materially factual and timely manner. When we talk about how we resolve complaints in a non-disciplinary fashion. Either the complaint is unsubstantiated because there was no violation of nursing law. The board can choose to issue a letter of concern stating what they are concerned about, what the nurse has done in a letter to the nurse, or they can issue what's called a consent decree. Those are for non-willful violations of the law. The nurse did not willfully violate the law. Disciplinary action is resolved with what's called an agreed order. The nurse should have known what they were doing was violating nursing law. Or we go to an formal administrative hearing. We also have what's called a credentials review panel, and that's a panel that meets monthly, and it has 3 to 4 board members that serve on this committee. It is closed. It's not open to the public because investigative cases are discussed in this meeting. And the chair of this committee appoints 1 board member to review all convictions and actions on another professional license monthly and direct disposition of those cases. If you have questions regarding the disciplinary process, you can go to the website at kbn.ky.gov and go to the investigation and disciplinary process, and then review the disciplinary process and procedures brochure. Here are some examples of violations that do result in disciplinary action. We have inappropriate delegation, documentation errors, abuse and neglect of patients, willful failure to meet mandatory continuing education requirements, medication diversion, prescribing violations, boundary violations, action in another state on a professional license, certain convictions of misdemeanors and felonies, drug or alcohol abuse, willfully working as a nurse without a current active license, HIPAA violations, including social networks. Let's see here. Now, when we talk about social media and nurses, we are seeing an increased complaints alleging misuse of social media by nurses. Good guides to always look at are American Nurses Association Code of Ethics for Nursing, social media nurses. Kim went over our advisory opinion statement. The National Council for Nurses, State Boards of Nursing has a nurse's guide to the use of social media. The KBN Connection had a winter article in 2018 about social media. as well as a professional boundaries, a nurse's guide to use of professional boundaries through the National Council of State Boards of Nursing. Even the appearance of impropriety can be detrimental to patient trust and the ability to provide care. When it comes to principles for social networking and the nurse, this is from the American Nurses Association, 2011. You want to avoid transmission or online placement of individually identifiable patient information, okay? You want to observe professional boundaries when interacting with patients on social media. You want to always evaluate all social media postings with the understanding that postings could be potentially viewed by others, patients, colleagues, educational institutions, or employers. And remember, people can screenshot your post. Tips. Avoid situations where you have a personal, professional, or business relationship with patients. Understand post-termination relationship dynamics, dating, personal relationships with former patients, small community settings. Patients may be neighbors and friends. The National Council, State Boards of Nursing have really good guidelines about post-termination relationship dynamics with patients. Red flags. If you are discussing intimate or personal issues with patients, engaging in flirting behaviors, showing favoritism with patients, you're keeping secrets, you have that belief that you're the only one that can help this patient, spending more time than necessary with a particular patient, making derogatory statements about your colleagues or employer to a patient or family. You're meeting the patient in settings beyond the normal patient care area or when not at work. Some of the good, the bad, and the ugly of social media. Some of the good things are there's forms of networking communication via various online communities. There's personal sharing of information, ideas, messages, and other content. It can enhance collegial communication among peers and nurses. And it provides opportunities for continual professional development, and it can be a valuable healthcare tool. But there's always the potential for violating patient confidentiality. You may damage trust in the healthcare providers, serious consequences for inappropriate use. It can damage a nurse's personal and professional future. There's violations in employer policies, even when off duty, that can result in termination or discipline. Non-compliance with relevant state and federal laws, civil and criminal penalties. And there can be personal lawsuits for defamation of character or invasion of privacy. And once again, there's these two videos that you can click on through the National Council of State Boards of Nursing for social media, as well as the professional boundaries in nursing. Consequences of inappropriate social media uses are employment ramifications. There can be academic dismissal from nursing programs. You can actually have a nursing license discipline for negligently or willfully acting in a manner inconsistent with the practice of nursing. You will have violated any provisions of that chapter, and you will have violated confidentiality of information or knowledge concerning any patient, except as authorized by law. And there is a duty to report that. Civil prosecution and criminal prosecution as possible. So stop and think before you text, email, and or post to a social media outlet. Consider, does the content relate to a patient, coworker, or employer in any way, whether directly or indirectly? Remember, is it possible to violate Kentucky nursing law regarding the patient confidentiality without necessarily violating HIPAA? Review the social media policy for your employer or your academic institution. Posts from private accounts can still be shared or viewed by others. And like I said, people can still screenshot lots of things. Maintain professional boundaries with the nurse and the nurse-patient relationships. Adhere to all policies and best standards of practice. Never complain about or comment about patients, families, employers, or coworkers. Post photographs or videos of patients, even with consent. Rant about your place of employment or use offensive language. Create or share offensive posts. Okay, so I am going to, because I want to be able to see, hang on. Let me see something here. So I'm going to share some. I want to share a couple of case examples with you all right now. I'm going to give you a case example of a social media case right now. You all can put it in. Put it in the chat. You can just say yes or no if you feel that this was definitely a violation or not. This was actually my case. I offered a settlement offer to this nurse to settle the case. She did not want to settle the case, so it went to hearing with our board. Okay. And I'm going to read some things from this case. This nurse had listed that she was an RN, where she worked at, was listed on her Facebook page. Okay. And these are the comments that she had listed. All this gunfire in Lexington gives me job security, but makes me scared to live here. Not to mention 9 out of 10 times, if a person is trying to kill you, not hurt you, kill you, there's a good reason. In parentheses, most gunshot wounds, well, or to put it nicely, I'd like to stick my finger in the bullet wound and make it bigger. We had one guy that was probably one of the nastiest persons I'd ever met. I truly wish the surgeons had given up on that one. I've come so close to knocking an entire family's teeth down their throats, but I noticed that someone else had beaten me to it, with 4 emoji happy faces beside it and 1 emoji sad face, feeling pissed off, in need of a job. At this point, I'm not picky. Anything will do. Can't take nursing any longer. If no job's available, we'll take charity. I'm not too proud anymore. No, not number 12. This was in response to another person's asking if she was referring to the patient in number 12, in room number 12. So I did feel like this was a social media violation. And like I said, I offered a settlement offer. She didn't accept it. So we did go to hearing. Our board decided that this was a violation and that nurses deliver care in a manner that preserves and protects the healthcare consumers' autonomy, dignity, rights, values, and beliefs, recognizes the centrality of the healthcare consumer family as a core member of any healthcare team, upholds the healthcare consumers' confidentiality within the legal and regulatory parameters. The nurse in all professional relationships practices with compassion and respect for the inherent dignity, worth, uniqueness of every individual, unrestricted by considerations of socio or economic status, personal attributes, or the nature of health problems. The nurse promotes, advocates for, and strives to protect the health, safety, and rights of the patient. The nurse participates in establishing, maintaining, and improving the healthcare environment, conditions of employment conducive to the provision of quality healthcare consistent with the values of the profession through individual and collective action. So she was cited with violating, acting negligently or willfully in the manner of inconsistent with the practice of nursing. She violated any provision of that chapter, and she violated confidentiality. She was given 30 hours on continuing education on legal ethical issues in nursing. She had to pay $863 in stenographer fees, $350 in hearing fees, and $250 civil penalty. Okay, this was a case where we had a nurse that was working on his privilege to practice in Kentucky. He was working here from North Carolina. He admitted to recording on his cellular device, having sexual contact with the patient and recording it on his cellular device while he was working in Kentucky on his privilege to practice from North Carolina. Our board gave him a civil penalty of $5,000, reprimanded him, and gave him a 52-hour contact weekend professional boundaries course that he had to attend as well. So he was going to have to fly to another state as well and pay cost, flight, and to attend this weekend course. So that was a case where someone was practicing on their privilege to practice. This is a case where it actually has to do with using fraudulent credentials. It was a decision from our board where a nurse applied for her RN license, and she submitted a fraudulent transcript. And she actually went to hearing on this, and our board permanently denied her application. Let's see here. This is a good case where this nurse was under investigation for a complaint where she was signing out Dilaudid without a physician's order, and she refused a 4-cause urine drug screen. And while she was under investigation, she got on our website and she looked for a nurse's license number under her maiden name, and she took that license number and stole it and used it on an application for employment. And when she went to apply and use that other alert nurse's license number for employment, that license number came up as being licensed in 1987. She was licensed in the 90s. Her resume started in the 90s. So that employer knew something wasn't quite right, contacted us. And we ended up referring the case to the county attorney in which she applied. They ended up pursuing charges on her for theft of identity, and she pled guilty to theft of identity for stealing another nurse's license number, which was a Class D felony. She was put on discipline with the board and has since been suspended for not being able to meet the terms of that order. Hang on just a minute. I want to get back down here. It's the next case I'm going to talk to you about. I want you to just have a couple more I want to talk to you about. Okay, Kathleen Wise. Snapped, season 10, episode 18. Our board did an immediate temporary suspension on her. Let me see the exact date. It was July of 2011. Then they later revoked her. But she's now serving a life sentence for murder at Kentucky Correctional Institute for Women in Pewee Valley. But she had been diverting morphine from her employer, and she was giving it to her husband in his drinking water simply because she said she was tired of taking care of him. But if it had not been for an astute coroner at the time when they found him and just by chance, he did a toxicology report, and the report came back with extremely high levels of morphine in his system. She would have never been caught. So this is a real interesting case that we had. Snap season 10, episode 18. Kathleen Wise. Yeah, her marriage flatlined when her husband dies from a lethal dose of morphine. And like I said, she's serving her sentence at the Kentucky Correctional Institute for Women in Pewee Valley after being found guilty of intentional murder. And then there was a mini series made. I don't know if any of y'all saw this one on Bravo a couple years ago, Dirty John Meehan. My supervisor actually had this case. He was ultimately killed in California. He had a life of diversion. He had addiction, theft. He stole fentanyl, Demerol, Versed. He actually had his pistol in his in the OR with him. He actually applied to Kentucky as an advanced practice registered nurse. He had many convictions. He didn't do anything he was supposed to do for our board, including a substance use disorder evaluation. And so eventually our board just denied his application, and they did it for a period of 10 years. But he first came under scrutiny by Ohio police in 2000. And that happened because his ex-wife brought a wooden box and a white basket that contained vials of medications later found in the home where he lived, and that triggered the entire investigation. He used medications because of his addiction. He worked in 4 states as a CNRNA in Indiana, Kentucky, Michigan, and Ohio, and stole medications from all 4 of those states. And he was eventually killed by a knife by a woman he attacked in California in 2016. It was the daughter of a lady he was dating. Jeff, the general counsel, is going to go through the administrative hearing process with you all in much more detail and the expungement laws. I would like for you all to note this, nurses e-notify. It's about licensure status, license expirations and renewals. It also reports public disciplinary actions, alerts, and notifications. It's free to subscribe to for all employers and licensees. It's nurses e-notify at ncsbn.org. And here is our contact information for our branch. And I want to thank you all so much for listening. And I think you have another break coming up. Let me double check here. I think there's another break coming up until 11:30. And then next will be our general counsel, Jeff Prather, with you all. And then we will answer questions at the very end. Thank you so much.
Good morning again. By my clock, we have 11:30. So I'm going to start back up. My name is Jeff Prather. I'm general counsel with the Board of Nursing, and I know that we are rolling into the lunch hour. Please do not hold that against your presenter. I'm here today to talk to you guys about the disciplinary process, from complaint to appeal and all points in between. Some of this information will overlap with what Chrissy said, but this has to do primarily with the disciplinary process and the hearing process. A little bit about myself. I've been with the state for about 16 years. Most of my time with the state was as a special prosecutor, prosecuting criminal violations throughout the state, misdemeanors, felonies, that sort of thing. I came to the Board of Nursing in March of 2020. And then in May of last year, I transitioned into the role of general counsel. So I'm almost at my first year date. Let's see. And in special in legal services, what we did was we would take cases to hearing we had a violation, and that's what we're here to discuss right now. So, as you've heard, Get my slide to advance. The board regulates the nursing profession. Our mission, of course, is to protect and safeguard the health and safety of the citizens of the Commonwealth of Kentucky. Of course, that's covered under 314.021. And we investigate nurses who have allegedly violated the Kentucky nursing law. And this is to protect the integrity of the nurse and nursing profession as a whole. So, we do receive complaints that are not substantiated. So it's good that a nurse, even if someone is out there saying something that is not true, that we can also clear their name. So let's take a look at the nursing code. When we talk about the nursing code, what are we talking about? We're talking about the statutes and the regulations, and those are enacted by the General Assembly and signed into law by the governor. If you've been paying attention to the news, watching what's been going on in Frankfurt, we've been doing that. We're coming to the end of a session, a legislative session, where there have been several laws that have been signed in, and there have been some nursing laws that have been changed recently. Not particularly with what I'm going to be discussing today, but having to do with the nursing shortage and how we can address that at the nursing board. Now, I'm digressing, but I just want to give you an idea that this is a process. It's a living process. It's happening right now. The nursing laws are covered under Chapter 314, KRS 314. That's Kentucky Revised Statutes again. And the statute that covers violations, discipline, primarily is 314.091. The disciplinary hearings, or administrative hearings, are covered under KRS 13B. Those are administrative hearings throughout the state generally, and we abide by those statutes when we have to take a case to hearing. Also, that we have open records, and I'll explain how that comes into effect with regard to complaints and hearings and how that progresses. Now, you've also heard about the Kentucky administrative regulations, the ones that pertain particularly to investigations and the discipline. They are 201 KR 2161 and 201 KR 2162. And these regulations allow the board to be a little more nimble, to flesh out statutes when it might not be clear. And so we are able to enact it. There is a process to enacting regulations, but it is a much quicker process than the legislative process that goes into enacting statutes. All right, so specifically, when we have a violation, who has a duty to report? Well, under the nursing law, the duty to report is mandatory. Any person that has knowledge, generally speaking, has a duty to report. That includes the nurse, the person who may have had the violation. If a nurse feels, or a licensee feels that they violated nursing law, they should file a self-report. And if it turns out that it wasn't a violation, well, generally we'll let them know it wasn't a violation, that's okay. But also the nurse's colleagues, if they see something, they have a duty to report. So do their employers and facility personnel. We also receive complaints from consumers, patients, their families. Now, that is all that statute that covers that. Again, there is 314.0314, and that discusses the duty to report. Now, any violations detailed in 314.091, are subject to this reporting requirement. I'm going to show you those. Now, I'm not going to go through and read all these to you, but it might behoove you to call up, just Google KRS 314.0911, and you can see in here what some of the violations are. Okay, fraud or deceit, being convicted of a misdemeanor or a felony, and I'm speaking very generally now. Acting negligently or willfully inconsistent with the practice of nursing, And here I'm reading them when I said I wouldn't, but you get the idea in those two columns. Now, the ones that are in bold, those are a little tricky because they refer to the rest of the nursing law. Other violations of 314, for example, or if there is a order by the Board of Nursing, if a licensee is ordered to do something, failing to abide by that order is a violation. And then also failure to abide by certain regulations is a violation. And we'll talk about some of these that can trip up nurses who actually have complaints filed against them. Okay, well, we will discuss these things, but I just want to put that there so that everyone seeing this has an idea of what the typical violations are. Now, the penalties, the board has the right to reprimand, deny, limit, revoke, probate, or suspend any license if they find that there's a violation. Now, this is done after a hearing. There's other cases where it may be more immediate, but we'll discuss that. The board also has the ability to impose a civil penalty up to $10,000. Okay, so in addition to some of these other penalties, this is kind of what we're talking about. So it's pretty serious, pretty serious. So, and then we have also penalties in the statute there. It's 314.990 for impersonating a nurse. So, but let's talk about more specifically complaints, okay? Because as a licensee, as a nurse, you have rights, okay? You have your license is a property right, and you have a right to that. But you also have responsibilities, obligations under statute, under regulation that you have to abide by. All right, so we get a complaint. Complaint is submitted to the Board of Nursing. And what happens? What do you do? You know, you get that dreaded letter from the Board of Nursing, and you open it up, and what are you supposed to do? Okay. First thing you want to consider is make sure your address is correct, because if you don't get that complaint and it comes back to us, that's going to be a problem. Okay, because you have to have an address of record with us so we can notify you of important messages, including these complaints. Okay, so if we send a complaint and it comes back because you're no longer at that address, that's a compounded violation. So make sure that your address is up to date with the board. Now, that said, when you receive this complaint, what should you do? You have a duty as a licensee holder within the Commonwealth of Kentucky, to cooperate with us, with the board, regarding this investigation, okay? And to provide information in a factual and timely manner, all right? So in failing to do that, again, and you're going to hear this, I'll probably say it several times, if you don't do it, that's a statute. Remember, 314.095 is another statute. And if we go back to 314.091, when we talked about violations, failing to comply with a statute could be another violation. So please, please, please make sure you cooperate. Make sure all your responses are timely. Okay. Now, here's what we do first. Okay, if you're a licensee and you receive a complaint, you will be asked for a written response, a verified written response. Okay, and this is under that one of those regulations that I talked about earlier, 201 KR 2161. You have to respond in writing within 30 days. You have to respond within writing within 30 days. Now, if you don't respond, you're probably saying it with me now, could be a violation. Okay, so make sure that you send in a timely response. All right. The investigators, when I say the investigators may request an investigative meeting. Okay. If they request an investigative meeting, failing to work with the investigators to sit down for that meeting could be another violation, because again, you have a duty to cooperate. You have a duty to cooperate with the investigation. All right. Now, I talked about earlier open records. Now, open records, because the Kentucky Board of Nursing is a state agency. Open records plays a role also under KRS 13B. Remember the administrative hearing statutes. Open records plays a part as discovery, and discovery is what you're provided. So you know what, you can understand what the investigation is, possibly what some of the evidence is. All right. Now, there are certain exemptions to that. For example, patient records. We can't just release patient records to anybody who sends in a request, even a nurse who might be under investigation. Mental health evaluations or internal notes, for example. We don't, the internal notes from the board are not subject to open records. But you are entitled to statements against you. You may not be entitled initially to who the person is until we get to a hearing, but you at least get an idea of what they're saying and why they're possibly saying it. The open records request must be written and must be specific, what documents you're looking for. There's no duty to just provide information. And there's no standing open records request. So you can't just say, I'm sending in a letter, please provide all information, and anything else you get, send it to me. It doesn't work that way. You have to renew it every time. But once we get a request, if it's specific and we can respond, we will. All right. All complaints are treated as preliminary and confidential. Okay. And the board doesn't disclose that to the general public, except as provided under 314-475, which is the nurse licensure compact. So when we have certain complaints, if we do get a call or and we're asked, hey, is this nurse under investigation? We have to say yes or no, this nurse is under investigation. However, at that time, we don't go into the facts. We don't say, and they say, well, what was the complaint? Like, well, we can't get into that. We can't talk about that because at this point, we don't know. Okay, there hasn't been a formal finding yet. All right, but once there's a formal finding, then it becomes public knowledge. So, but we do, under the regulation, we do have to say that investigation is in fact pending. Now, we get this question all the time, especially when we have nurses that are traveling out or traveling in other states. Can they continue to work? Even if you have a complaint, can you continue to work? The general answer is yes. Yes, a complaint is just that. It's just an allegation. We have to let people know again that the investigation is pending and it's confidential. But unless there are other restrictions for other reasons, the nurse, the licensee, can continue to practice, assuming that it's current and there's no other active discipline on the license. What we can do, we have nurses that are endorsing into other states or primarily endorsing in other states. They may send us a request for an affidavit saying, yes, this nurse has an active license. And if that's true on the date that we receive the request, then we can provide an affidavit to that effect to the state. And it's fairly standard practice. Now, when we're talking about this, we also talk about dialysis technicians. They're under the same. We have to follow the same laws regarding dialysis technicians, and we will provide that information as well, the same as we would with the other licensees, credential holders with the board. Okay, now, as part of the investigation, the complaint may raise issues that the nurse may not be able to work with reasonable skill or safety, or they might be abusing alcohol or drugs, or we have other flags that we're concerned about. Now, the board has the authority to request, as part of the board's investigation, that the licensee undergo a mental health or substance use disorder evaluation. They might also, some of the other issues, Chrissy was talking earlier about inappropriate relationships. if that is an allegation, they might even they might even order a neuropsychological or a psychosocial or psychosexual evaluation with an appropriate evaluator. Okay, now that's under KRS 314.085. And again, failing to get that evaluation is a violation. Now, and not only is it a violation, we'll talk about this also a little bit more, it can have your license temporarily suspended until you get that evaluation. Okay, so, and this is something that every licensee consents to by having a license to practice as a nurse in Kentucky. You consent to this. And so if you don't do it under KRS 314.089, not only is it a violation, but again, you can have your license immediately temporarily suspended until you abide by that order. Okay, so again, please make sure that you abide by the orders, answer timely, and don't compound what is already a problematic situation. Okay, now, not all complaints are equal. Okay, when the complaints come in, our investigators experience several years among all the investigators in evaluating these complaints. When they take a look at it, they review it under KRS 314 to see if there is a colorable claim. Now, what is a colorable claim? It means that looking on the face, yes, this is a violation based upon the claim, assuming it's true. Okay, now, if there are questions about how a case is resolved, these cases may be referred to the credentials review panel, which is a panel that's formed of board members to review each case, the facts of each case, to decide, is this something that needs to go forward? Okay, is this a case that we really that can we close this case out? Can we offer? Can we make an offer to resolve it that is less than discipline? Those are the types of things that go to the credentials review panel. If on the face, the investigator may even look at it and say, there's nothing here, and I'm going to close it out. And then after review with board staff, legal, that may happen. Okay. Now, as part of making this decision, they may also send out subpoena. They may have, the board has subpoena power. Okay, under 314.0913, and as so the board can send subpoenas to the facility if it's a facility complaint, or to other institutions requesting information regarding the complaint to see if the allegation is supported. All right. Now, as I suggested, the board may close the case. The claim is unsubstantiated. They say, okay, there's nothing here. There's nothing here for us to take to a hearing panel, so we're just going to close it out. And if that happens, if you're aware, you will be notified. Now, the next step, and again, this is not discipline, but there is the nurse may be sent a letter of concern, which expresses a concern about the alleged violation. If there's something that, it just doesn't sit right with the board. However, it doesn't really rise to the level of discipline or a resolution, a civil resolution. Okay. Now, beyond that, there are negotiated resolutions. Okay, and we're talking about basically a resolution that is agreed to between the board staff, and the licensee. Okay, and those are consent decrees, agreed orders, and then there are care agreements. Excuse me. Now, I'll take a drink real quick. Okay, consent decrees are limited to minor incidents that incidents that are not intentional. Okay, so when this agreement is signed, the licensee waives the right to a formal hearing. Okay, and it closes the case, but the licensee agrees to pay a penalty Probably has to do some continuing education regarding the nature of the complaint and the resolution. And this is above and beyond the 14-hour CE requirement that nurses have to have every year. Now, important to note, consent decrees are not discipline. Okay, they are not reported to nurses. Okay, they're not put on the website. It may go out, generally speaking, in a KBN connection that how many consent decrees there were, but there is no specific reporting of it. Now, again, we talked earlier about open records. If a person were to say a potential employer were to send us a request and say, do you have any prior investigations with this licensee? At that point, any documents resolving that, we would have to turn that over. Okay, but again, it's not discipline. And I want you to pay attention because consent decrees can be a little tricky, because if it happens again, it can, because remember I said earlier, up above at the top of the slide, it says it's non-intentional. Now, if it happens again, that could be a reprimand. Okay, but I got a tip for you guys coming up, so pay attention, watch for that, and we'll talk about agreed orders. Okay, an agreed order is a settlement of a case, and agreed orders are discipline. Okay, again, the licensee or applicant waives the hearing right, admits to a violation of the code, but negotiates with the board specific terms of that discipline. And they sign it. And again, counsel, you can talk to an attorney about this. You can talk to an attorney about any of this. If you get a complaint, feel free. But once it's signed, it has to be approved by the executive director. And it has an agreed order. It's like a contract between the board and the licensee, and it has the full effect of a decision that was entered by the board. Okay. Now, the board does not issue a formal statement of charges or or a notice of hearing when an agreed order has been signed. Okay, so it stops the process, but the agreed order then becomes public knowledge, gets uploaded to nurses, and it is in fact discipline. Okay, so let's talk about agreed orders and what actions there are against a license with regard to agreed orders. Okay, it's a reprimand. There could be it's discipline again, and it may not necessarily affect the licensee's ability to practice. Okay, there's generally, like a consent decree, there's a civil penalty, continuing education, possibly drug screening if it's appropriate under the circumstances. Okay, now for more serious cases, more serious practice cases, or cases where a licensee may need monitoring because there's an allegation of a substance use disorder, then it might get more severe. Okay, and under this situation, the agreed order is for a limitation or probation of the license, and you can see I've listed there in that little paragraph at the end some of the potential limitations, like not being a manager, not being able to access narcotics or medication. You may have to meet with you will have to meet with a case manager occasionally, turn in documentation. Okay, now this is, and again, we're getting more progressively more severe based upon the nature of the violation. Okay, so aside from monitoring, it may come to a point where a licensee is going through certain things in their life, and at that point they just decide it's better for me to just surrender my license. So in this case, they surrender their license for a period of years. Generally it's around 2, and then they have to possibly go through monitoring when they come back. So They have the same sorts of monitoring management when they get back, but sometimes the licensee feels that's the best for them in that situation. Okay, now they could also agree to being suspended for a specific amount of time. And when they do this, and it includes when they come back, we talked about monitoring, they may have to get an evaluation when they come back, counseling reports, have drug screens. And again, all these terms depend upon the nature of the violation. Okay. And and if they do all these things, or it turns out that they think the licensee believes that they should be reinstated, that they've accomplished it, but there's a disagreement, then they have a hearing right to resolve that issue. So they can have a hearing right before the board or before a panel. Okay. And that's what I just talked about with reinstatement. If it's denied, you do have a hearing right, or licensee would have a hearing right. And that may happen with with actions in other states. So if we also have, say, a nurse is applying for licensure, say they weren't licensed previously, but this is their first application, say they're endorsing in from another state. If they have action in another state or other convictions, or they don't report those, though they can be denied. They can be denied. And again, there's a hearing right if they're denied to respond within a certain time, and they can apply to have the panel make a decision. Okay. So, and then finally, there's revocation. Revocation can be permanent. And in the case of revocation, the licensee may be required to take the NCLEX again. Now, this revocation is an extreme remedy in these cases. It's not something that we see a lot of. Generally, it's suspensions, agreed suspensions that tend to be the extent, but revocations are not unheard of. All right. So the terms that are in the agreed orders and the consent decrees are based upon those that are approved. They've been approved previously by the board. Now, that is not to say that everybody gets the same terms, but the terms as written, should they apply to a particular case, have been approved. Okay, so there's not a lot of wiggle room. Staff doesn't have a whole lot of wiggle room negotiating, changing those specific terms. All right. Now, again, I mentioned earlier that consent decrees, agreed orders are like contracts. Failing to comply with the terms of a license or with an agreed order, getting the CEs, paying the penalty, paying the civil or paying any fines, could result in the license being suspended or not being reinstated. So, and they all generally say this. Now, and when the agreed order consent decree is signed, the nurse, the licensee, specifically agrees to this. And if there's an issue of noncompliance, say, for example, in the case of monitoring, the nurse will be given notice, hey, you're not in compliance with our agreement. And the nurse at that time can have the right to have a hearing. Okay. And if they don't request the hearing, then they can be suspended. All right. Now, discipline in the nurse compact. There are certain violations that will prevent a nurse from having a multi-state license. It'll limit them to a single state license. So if there is a federal or state felony conviction or agreed disposition, a finding of guilt as to a felony charge, if there's a misdemeanor conviction, a federal or state misdemeanor conviction related to practice, or if the license is encumbered in monitoring or in an alternative to discipline program. Okay, and that's all covered on a 314.475. That's standard. That's not a Kentucky law. I mean, it is a Kentucky law, but it's not singularly a Kentucky law. It is a law that is part of the compact that every compact state follows. Okay, and they will have different, ours is KRS 314, 475. You go across from state lines, they're going to have the exact same language, but it'll be under a different statute. And if you're practicing out of the state, you need to know the laws in that state. Okay. Now, how long does a CD, a consent decree, or an agreed order, an AO, last? Okay. Under regulation, a CD stays on your record or is there for at least 5 years. When I say at least 5 years, if you want to have it expunged, we have to receive a written request. Okay. But after 5 years, if you have abided by the terms, you've paid the fine, the civil penalty, completed the CEs, send us a letter. We're glad to expunge it. Happy to do it. Okay. Agreed orders, simple agreed orders and reprimands, those are 10 years. Okay. Reprimands that don't involve necessarily monitoring, but not urine drug screens fall under this category. They last 10 years. Okay. Now it's 10 years from them being cleared. And when I say cleared, what that means is you've met all the terms, you've completed the agreement, and there hasn't been subsequent discipline. Okay. So that kind of starts the clock all over again. So 10 years, that's a long time. So as long as you abide by everything and don't have any other issues, you can get that expunged as well. Now, decisions by the board that actually go to hearing and other monitoring, those types of agreements, those last 20. Okay. And the conditions are similar to the other agreed orders. You have to meet all the terms of the agreed order before it can be cleared. And you can't have subsequent action. Okay. So if you get into trouble again, it's gonna back that clock up. So you got to make sure that you, if you have discipline on your license, that you try not to get any more, because it just it stays there. It doesn't go away. Okay. Here's the pro tip I mentioned earlier. All right. I talked about consent decrees. And if a licensee has received a consent decree and they get another allegation of similar conduct, okay, the second one or third one, has to be an agreed order, or has to be a reprimand, has to be discipline. Okay. So here's the pro tip. If you have a complaint pending against you, and it's been 5 years since you received a consent decree, you should consider reaching out to board staff and asking to have the prior consent decree expunged. Now, there is no requirement that a consent decree not be expunged if there's prior action or subsequent action. Sorry. So go ahead, and if you have a prior consent decree and then you receive another complaint, it doesn't hurt to have that other consent decree expunged if it's been at least 5 years and you've met all the terms, because then that prior consent decree is not going to be a factor in how board staff, it doesn't tie board staff's hands under the regulation about resolving that issue. Okay, so let's keep that in mind. 5 years on a consent decree, send us a letter. If you've met all the terms, we'll be glad to expunge it. Okay, now, another resolution that we have is the Kentucky Alternative to Recovery Effort, CARE. Okay, those CARE agreements. It's similar to limitation and probation, but it is very specific to substance use disorder, and it has to be requested by the licensee when the complaint comes up and the licensee says, I have a substance use disorder. I would like to be considered for CARE. Not everybody can go into CARE, but they have to ask to be considered for it. And if they're accepted into the program, it's a 5-year program, and it's a difficult program. But at the completion of it, and when I say difficult, I mean there are several obligations. But once it's completed, there's no discipline on the licensee's license. Okay, and the goal is to allow the nurse to continue working as long as they're addressing the substance use disorder, and they want to address it. Okay, now what happens when we have a complaint and we send it out and we evaluate it, and the board staff and the licensee, the nurse, can't reach an agreement about how to resolve it. Say, no, I don't want a consent decree. I don't want that agreed order. I can't do it. Okay. At that point, the formal administrative hearing process starts. All right. So let's talk about the conduct of the hearing, who's on the panel, and what are your rights? Because you have due process rights. Okay. Pleadings for hearings. Now, if a case is not resolved, a formal notice of charges will be drawn up by legal services. The case is referred from investigations to legal services, and it goes out. If you receive a notice, if you had a complaint, and if it's ignored, but if you receive a notice, okay, it's similar to the complaint itself, but this now it's taken on a formality, and the stakes are much higher now, because if you don't respond to this, you could default, and it's as if you admit to everything. It's like you say, I did it, and if you don't respond, then it can result in a default. But it's not just a letter, it's a formal notice. Okay, so make sure when you get something from the board, you read it very carefully. Okay, it informs you or informs the licensee or the respondent. At this point, they become the respondent. Okay, because now that's the role in this legal proceeding of the specific charges, the allegations of fact, not necessarily all of them, but enough to give you an idea, or give the licensee an idea of what they're being charged with. It'll be a statement of the law and the legal rights, and that this is a probable cause finding. Okay, and probable cause is simply that the facts which the claim is based upon is valid. Okay, and it's a very low standard to find probable cause, but that's what is stated within this formal notice. Okay, now once the formal notice is sent and the respondent responds, okay, and the respondent again has the right to counsel. But once the respondent responds, the hearing officer under 13B, the 13B hearing officer will schedule a hearing to discuss any issues with the case, preliminary matters, and set a hearing date. Okay, and usually a hearing date, depending on the schedule, could be several months out. All right. Now, you have to understand that once you receive this notice, there's an exclamation point there, a bang. The respondent is required to file a response. Okay, it's called an answer at this point. To participate. If they don't participate in the hearing process, it can again result in a default. Again, it's an admission to the charges, because if they're not answered, you basically say yes, they're true. Okay, so you have to dispute them if you're going to dispute them. And the hearing officer can issue it if there's no disputing, or if there's no answer, there's no response, the hearing officer can issue a default order, and which can result in a formal decision as if the case had gone before a panel, before a full hearing. Okay, so again, we talked earlier about this with regard to the open records. The open records is the discovery mechanism, CARA 61. So a party, either party now, in this case that includes the board, has the right to inspect at least 5 days prior to the hearing any evidence that the other side wants to use. I understand the practice, our practice of legal services is to provide the information well before that. But if there's evidence that the licensee doesn't provide within that 5 days, the board can say, we're going to object to that. We don't want that to be part of the evidence in the case. And the panel can only make their decision based upon the evidence in the case. So make sure you abide by those timelines and that if you have evidence that you think mitigates or exonerates, document, if you have those documents and your case is going to hearing, you want to make sure you get it to board staff, so that they have a chance to review it in advance, so that neither side is blindsided during a hearing. Okay, so let me make sure all right. And so this will all be spelled out in an order from the hearing officer regarding discovery. All right, so the hearing officer will send this out, and so that it'll have the timeline. Your hearing's on this date, discovery is due by this date. So make sure any orders that you see, any pleadings, you read them very carefully if you find yourself in this circumstance. All right, so what happens at a hearing? Okay, hearings like a hearing is similar to a trial. Okay, it consists of 2 board members and a hearing officer. Okay, there's also the prosecuting attorney and the respondent and counsel, should the respondent choose to have counsel. And then there may be other board staff present, investigators, and other witnesses who testify. Okay, hearings are open to the public. And again, they're governed by KRS Chapter 13B. Now, let's talk about the board members. They are the finders of fact. Okay, there's 3 there at the during the hearing. The 2 panel members act as jurors, essentially. Okay, so they weigh the facts. They have the ultimate say in what happens with the license. The hearing officer is there to call balls and strikes, essentially. Okay, so all the decision has to be based upon the evidence at the hearing and properly admitted evidence. And the board members can't know the facts prior to sitting on the panel. I talked about CRP earlier, where they would review cases to say, hey, can we resolve this case? If a panel member had sat in CRP, they would not be on the panel because they can't have prior information about the case before sitting on the panel, because they can only make their decision based upon what they hear during the hearing. All right. Now, again, the hearing officer is a licensed attorney, acts as the judge, rules on the legal issues, and if there's a tie between the panel members, so when they deliberate and the panel members say, each panel member has a different opinion about what the outcome should be, the hearing officer is there to break the tie. All right. Now, the prosecuting attorney is the counsel for the board, represents the board, brings the statement of charges, and presents the case to the hearing panel, and also will litigate any post-hearing matters. Okay, so there's an appeal, for example. We'll talk about that in a little bit. Now, the respondent, that would be the licensee. They have a right to be present for the entire hearing. They don't have a right to be present during the deliberations. Nobody does. The deliberations are secret. And they have a right to a counsel of his or her own choosing, and retention. They're not appointed. You have to retain counsel for an administrative hearing. But you also have the right to confront, cross-examine witnesses. You can present witnesses. You can present your own evidence. You have the right to present rebuttal evidence. You also have the right to, under 13B, to you've got due process of law. So you get, there's a strict adherence to constitutional due process. So to secure those witnesses, you have subpoena power. All right. The executive director and the hearing officer have the right to subpoena witnesses in, subpoena documents to be presented in the case. Now, again, all this evidence has to be relevant, but if it's relevant, you have the right to bring it and show it to the panel and have it presented. Okay. And it's the same power that is in civil and criminal courts within Kentucky. Okay. Now, both parties may make opening statements, again, present the evidence, and all testimony has to be under oath. All right. They make closing arguments before the panel deliberates. It's very similar to a trial in those respects. Now, under due process of law, the board and when it's bringing the allegations, generally speaking, has the burden of persuasion. That means the burden is on them to prove the case. That is not always the case. If we have an applicant, the burden may be on the applicant because of the position they have. They don't yet have the license, and so the burden's on them. But once the licensee has their license, the burden shifts to board staff to prove its case to the panel. All right, and the case is proven by a preponderance of the evidence. Now, this is not a criminal trial. Everybody's familiar with beyond a reasonable doubt, which is the criminal standard. This is not a criminal standard. This is a preponderance of the evidence standard, which is a much lower standard. It means essentially that the licensee committed the allegation and they believe it more than 50%. Okay, that's generally how it's described. More than 50% that the claim is true. Okay, so it's a much lower standard than a criminal standard. Now, generally speaking, in hearings that the rules of evidence, the Kentucky rules of evidence, are followed. However, not all of the rules of evidence apply. For example, in administrative hearings, hearsay evidence is admissible. Letters from licensees, co-workers that they want to have entered on their behalf. You won't have to bring your co-workers in to say, hey, and testify on your behalf. They can provide a letter. All right. However, the decision of the case cannot be based entirely on hearsay. There's going to have to be testimony, and there's going to have to be, and the evidence has to be, generally speaking, what reasonable people would rely upon in making a decision of this nature. Okay, it shall be sufficient in of itself to support an agency's finding of facts, unless it would be admissible over the objections in civil action. So there could be other objections, but generally speaking, for other reasons it may not be admissible. But hearsay can be admitted in these cases. All right, and it's important to note that the licensee is probably always required to testify. Okay, at these hearings. Now, hearing costs. Okay, so if the decision is adverse to the licensee or the applicant, okay, if the licensee requests the hearing and it is, and the panel rules against them, it is adverse, then they're responsible for the costs of the hearing. Okay, if they win the hearing, then the board pays the costs. Okay, and so, well, what are the costs? Well, you have a court reporter who is called to transcribe the hearing. The hearing officer has a fee. Any expert witnesses that are called by either party, including travel for other witnesses. So it's something to be considered that, just asking for a hearing, you might consider, what are my chances, in succeeding? Because if I'm not successful, not only is my license in jeopardy, I'm going to also have these additional costs. Okay. Now, this slide, hopefully I'll be able to remove in the very near future. Proceedings during COVID-19 have been conducted using video. We've been using Zoom, sort of like this, with all the attendees. All the attendees could be present via Zoom. My understanding is that with the state of emergency ending, the hearing officer intends to go back to in-person hearings. Okay, but in the off chance that the unfortunate, if we have another event where COVID comes back, or we may go back to video hearings again. All right. Deliberation. After the hearing, the panel and the hearing officer go off to deliberate, and they issue a recommended order. Now, the recommended order is not the final order. It's just what the panel recommends to the board. Okay. And they do this in a closed session. they have a certain amount of days to provide it to the board and to be ratified. So the board accepts it and adopts it and says, this is the board's decision on behalf of the panel. The prior to when the licensee and the board staff receives this recommended order, they have the right to file exceptions, okay, within 15 days. And this is basically to clear up substantive facts or law with regard to the recommended order, so that if they have any objections to this recommended order, this is the way to file them so that their objections get heard by the board, the full board, before they ratify it. Okay, again, 15 days. So the final order is submitted to the board and for review and ratification, and they issue it, and it becomes a done deal. All right. And the order, again, based solely upon the evidence and the exhibits, not based upon something else, all from the recommended order that came through from the panel, and the exceptions if the board chooses to consider them to amend the recommended order. Disciplinary actions, once they become final, are placed on the KBN connection on the webpage. Nurses is notified. And again, they're subject, just like other state actions, to the open records law, KRS Chapter 61. And again, there's other agencies here that will be made aware of these decisions. All right. So let's talk briefly. I'm running out of time, but I'll try to get through this. I talked earlier about failing to get an evaluation, which might lead to an immediate temporary suspension. An immediate temporary suspension is similar to a finding by the board, but they can be issued without a hearing. Okay. However, if one is issued, it's an immediate temporary. So it's immediate. It can be issued without a hearing. It can be temporary because you can request an emergency hearing. Okay. Or the licensee. I say you, hopefully none of you have to ever deal with this, but just forgive that. If the licensee receives this, it's an ITS, immediate temporary suspension. It's an emergency action where the board sees that there is an immediate threat to the public. Okay, there's an urgent need to protect the health and safety of the public. Now, can an investigator just do this? Excuse me. Excuse me. No. In order for this to occur, the investigator takes this to the supervisor. It goes to the executive director and ultimately to the president, and the president makes a determination based upon the facts about whether or not a license should be immediately temporarily suspended to protect the public. Now, there are other reasons to suspend a license. Not paying your licensing fee, that can get your license suspended. But generally speaking, if the fee is paid, that suspension will be lifted. Failing to pay child support, that is another reason to have your license suspended. And again, failing to obtain an evaluation. But the vast majority are to protect the public. Okay, if it's determined that the public is in danger by this nurse having a license, then an ITS can be issued. All right, so what happens if an ITS is issued? Well, that kicks in the right to an emergency hearing. It has to, the request has to be in writing. Again, you want your requests, any correspondence you probably should have in writing with, especially when you're in the situation with the board, so there's a record, but the request needs to be in writing. And this does not, the request for hearing doesn't stay the order. It doesn't stop it. And that's why there's a hearing is set up to be held within 10 days. So the license will stay suspended until there's a hearing. So let me go back. The board, again, board staff has the burden to prove and affirm that this order was substantial evidence. Okay, so a little bit higher evidence that to require this, but it's heard by the officer, or heard by the hearing officer, and not the full panel, and the hearing officer makes a decision. Okay, if it's adverse, if the licensee loses that hearing, it becomes final. Okay, it becomes a final order, just like a decision before a full panel. And then the licensee can only appeal that decision, like other decisions, and we'll talk about this, to the Jefferson Circuit Court. And costs are the same. If it's adverse, those are borne by the licensee if they lose the hearing. All right, so a few minutes. The rest of this is fairly quick. What are the appellate rights? If there's an adverse ruling, the licensee loses the hearing, they can appeal. And the first appeal is to Jefferson Circuit Court, then it goes to potentially goes to the Court of Appeals, and then even all the way to Kentucky Supreme Court. Everyone has every licensee has a right to an appeal in the Jefferson Circuit Court. At this time, they become the appellant, and the board becomes the appellee. Appeals have to be filed within 30 days. Okay, 30 days after that final order is mailed. So once the board makes a finding, you got 30 days to appeal that. And so the appeals has to be based upon the record and legal issues. And they're not new hearings. Okay, no new evidence is going to be presented. If you could have presented at the hearing, you should have presented at the hearing. The court, generally speaking, is not going to consider new evidence. If that is unsuccessful, then the licensee can seek an appeal at the Court of Appeals. Again, there is a right under the law to an appeal at the Court of Appeals. Okay, so that's intervening between the Circuit Court and the Supreme Court. Again, 30 days. Same rules apply, no new evidence. And ultimately, if that is not successful, the licensee could seek review by the Supreme Court. Now, there is not a right to the Supreme Court reviewing a case. The Supreme Court may review it at their discretion. Okay, and if they're not going to review it, then that becomes a final decision. And again, if it's not appealed, if these decisions are not appealed within these timelines, they become final. So it's almost like we go back to the notice of charges. If you don't respond, it can become final. If you do respond, but then you lose a hearing, that can become final. If you have to keep, filing your appeals within the deadlines, you have to keep responding within the deadlines. If you don't want these to be final, if you don't want the decision to be final. Okay, and so that is the appellate process in a nutshell. Now, I've gone through a lot of information here in a very short period of time, and I'm about to hit my mark. I'm thrilled. I didn't think I was going to do it. But if you go online to the Kentucky Board of Nursing, there is a brochure regarding the disciplinary process. There is also an article regarding the disciplinary process. So they can be found in the document library on the Board of Nursing's website. So please, and if you have any questions, anything comes up, you can always reach me. Here's my contact information. I can't provide legal advice. I can just give you an idea of the process. You can also talk with our hardworking staff and legal services. That's my email, and that's my direct office line, my mobile line, and that's the Board of Nursing's website. And I understand we are taking questions at the end, but thank you. I appreciate the opportunity to discuss this with you, and I appreciate your attention. Thanks.
All right, Jeff, if you don't mind, could you go ahead and make me the host so that I can distribute that to Melissa Hadaway? And as I understand it, we're about to take a break here from 12:30 to 12:40.
Yes, that is my understanding. Let me get the participants and make host. You have it?
I do, and I have passed it on to Melissa.
Okay. Thank you, Eric. Thank you,
problem.
Melissa.
Thanks, Eric. Thank you, Jeff. So yeah, we'll take a break until 12:40 and we will start back then. Time to enjoy their few-minute break. We do appreciate you all being with us today and hope that you have found these sessions valuable. My name is Melissa Hadaway. I'm actually one of the nurse investigators, case managers here in the compliance branch of the Kentucky Board of Nursing. And I've been a registered nurse for 24 years. I've been here with the Kentucky Board of Nursing in my current position for the last 8 years. I started my career at the bedside, where I worked here in Louisville at Norton Audubon Hospital in the transitional care unit. And then I spent the next 14 years working for really in the public health community health setting, where I worked in a variety of outreach programs. I did encounter a lot of individuals that suffered from a substance use disorder. And then, like I said, I've spent the last 8 years here at the Kentucky Board of Nursing in the compliance branch. So what our branch does is we do all of the monitoring for nurses who are under any type of agreement, agreed order, a decision, also who are participating in the care program. We do all of the monitoring of those nurses. There are case managers where we have caseloads of nurses in various levels of monitoring. We monitor their compliance, we meet with them, address any issues of non-compliance that arise during their monitoring. It, depending on what the violation is, we do make recommendations at times for suspension of licensure. We work with nurses who would like to voluntarily surrender their license for a period of time if they cannot fulfill their monitoring agreements. Myself, and another individual in our branch, we also work with nurses who are seeking to reinstate their license following a period of disciplinary action. If the nurse has been suspended or they have surrendered their license, we also work with nurses who are seeking to reinstate. So we're going to spend the next few minutes talking about just an overview of substance use disorder and also the various monitoring that we do, whether it's the alternative to discipline, which is our care program, or the disciplinary monitoring. So when we talk about a substance use disorder, of course, a diagnosis has to be made. You are probably familiar with the DSM, which is a manual that assists clinicians to actually make a diagnosis and includes criteria. There have been several versions. The latest is the DSM-5. It was published in May of 2013. And it really addresses more specific substances now. Previous in the old versions, you would just see diagnoses such as substance abuse or substance dependence, whereas now, if the individual is using the most current version, you'll see more specific substances using the same criteria. So you may see the alcohol use disorder or cannabis or opiate use, the specific substance in the actual diagnosis. There can also be different grades to the disease as well, mild, moderate, severe, depending on how many of the criteria an individual meets. And then the clinician also may add the terms like early remission, on maintenance therapy. So I've given a couple examples of diagnoses that we see frequently at the board when we get the evaluations returned to us. What we know is that this disease is a chronic relapsing brain disease that's characterized by compulsive drug seeking and use despite harmful consequences. It is potentially fatal if it's not treated. Unfortunately, there's not a cure, but there is recovery. It's understood to be a brain disease because scientific research now shows that the prolonged alcohol and drug use can cause chemical changes in the brain and alter the brain's reward system that will prompt that compulsive drug seeking. When that system, which we know it as the limbic system, is overstimulated with substances, the euphoric effects are produced, which will reinforce the behavior of use over and over again. Eventually, an individual will build up tolerance where they require more of the substance to achieve that high or the same effect. And then in the absence of the drug, the individual will experience withdrawal symptoms, and then they need the drug or the substance, whether that's alcohol or substances, just to feel normal, to be able to function, to be able to get out of bed and do what they need to do on a daily basis. The person is usually maybe aware of their problem or aware that they do have a problem, but they're unable to stop on their own, even if they wanted to. Some myths and facts about substance use disorder is, the first one is that it's a bad habit, a moral weakness, or an overindulgence. It's a chronic, what we know is it's a chronic life-threatening disease that causes dramatic changes in the brain. While in the beginning, the substance use is a choice, the addiction is not. No one wishes that or wants that when they first start using a substance or they first start experimenting, with alcohol or other drugs. But the brain changes that are caused by that repeated use over and over again make it very difficult to quit using. Another myth is that an individual can stop using whenever they wish, when the reality is the power of the disease really perpetuates that continued use despite those repercussions. I think it's easy as someone from the outside looking in to wonder why the person just can't stop. And if they loved me, or if they cared about our family, or if they cared about their kids enough, they would just stop, or they're choosing drugs and alcohol over me. We have all these thoughts if you experience a loved one, a family member, friend that is struggling with a substance use disorder. But again, the definition that I just shared about the compulsive drug seeking and use despite harmful consequences, the person is not thinking about the consequences or, how that is outreaching to all areas of their life. They're simply in the midst of battling a disease that is untreated, it's out of control. So they're really not thinking about all of those things. Another myth is that many people relapse, so treatment obviously doesn't work. What we know is that treatment, it does not guarantee lifelong health and sobriety. What treatment facilities do is they help to remove that individual from their current environment of the use in an attempt to try to focus on, treatment for a period of time and teach them some lifelong tools that they can use to maintain their sobriety. And then a person has to want treatment for it to be effective. That's another myth. Many people with a substance use disorder typically don't seek treatment on their own. It's usually because of the stigma and shame that is associated with it. It could be due to other reasons, such as the cost of treatment. Oftentimes it takes a personal crisis for someone to seek and enter treatment. That could be a criminal arrest. They're facing a DUI or they get a DUI. They go to jail. Maybe it's their marriage is on the rocks, so they're facing, divorce, or the loss of their children, maybe custody of their children. But regardless of why someone enters treatment, it will work. Treatment does work. When we talk about, how many people are affected by this disease, the general population, about 14.6 are, expected. That's about 1 in 7 people in the US are expected to develop this disease at some point in their life. We as healthcare professionals, we are really in that same percentage as the general population. However, about 10 to 15% of healthcare professionals will misuse drugs and alcohol in their career. If we were in person, I would probably ask for some examples of that. I typically will throw out examples of misuse, such as you are prescribed maybe an opioid for post-op pain relief. Maybe you have knee surgery and you have some of that left. Let's say it's hydrocodone and you have some of that left over. And then instead of disposing of it, which is the right thing, the correct thing to do when you are finished using that medication for the post-op pain, an individual may, and nurses are really bad about this, about hanging on to that medicine, putting it up in the medicine cabinet. And then 6-8 months later, you pull your back at work or something else happens, someplace else, and you have pain and you realize that you have that leftover pain medication. And so you decide to use that. Even though it is prescribed to you, it is not, you're not taking it for the intended purpose that it was originally prescribed for. Another example of misuse would be either drinking alcohol more, overindulging, or possibly as far as medications go, taking more than what's prescribed or recommended. such as instead of 1 to 2 of the pain pills every 4 to 6 hours, maybe you start taking 2 to 3 and you take it in a sooner than it's recommended to take dose. So those are just a couple examples. Taking someone else's medication that is not prescribed to you. So that would be another example. And then we talk about some of the maybe high risk nurse groups for maybe having a substance use. Some people will say nurse anesthetist, nurses that work in the ER, OR, ICU, or psych, maybe at a higher risk. And that could be because of the stress that they experience in those areas, the types of medications that they have access to in those areas. However, anymore, especially in the last couple of years with what everybody has gone through in the healthcare industry with COVID, I think that there are many areas of nursing, if not all, that can be stressful at any given time. Some people are able to use substances multiple times without becoming addicted. Others may use a substance only one time when signs of addiction become apparent. But an individual's potential for developing a substance use disorder is affected by several factors, which include having a genetic component. That could be the family history of a substance use disorder, parents, grandparents, siblings, or having a mental health disorder. Could be some environmental factors, such as, maybe there was family trauma growing up. You grew up in a chaotic home, or there was abuse, various types of abuse, your peer influences, your access to drugs and alcohol growing up. Maybe it was accepted for when you were a teenager for you to drink or, experiment with drugs. And then when we talk about the age when use began, that is highly predictive of having a substance use disorder later in life. So the earlier that one started, especially in the teen years, if it was early teens or even before teens, we've seen that. But the more risk factors that someone has, the greater the chance that using drugs or alcohol could lead to a substance use disorder. These are some other characteristics when we think about the profile of a nurse with a substance use disorder. These are some things that you will typically see. There's usually that history of either having a substance use disorder and or trauma in the family. But these nurses who develop and have a substance use disorder are usually what you would characterize as an overachiever. They've usually graduated in the upper portion of their nursing program. They will, they're usually highly respected at work. They have those demanding and very, kind of stressful jobs where they have a lot of responsibilities. Their substance usage is not a social thing. It's alone by themselves. And they continue to feel responsible at work. Sometimes so much so that they may come to work because they don't want to call in sick. They may come to work impaired. They may not even realize that they're impaired on the job. But they are very demanding of themselves. They will deny any type of stress or depression or unhappiness. They'll put on that happy face like everything is fine. And typically I'll say this is someone who may get the Nurse of the Year award and they're recognized at work, and you would want this nurse to take care of you or your family. Can you tell by looking at someone who has this disease? It's not a trick question. I throw this slide in there to say, you maybe have worked or are currently working with someone who is suffering and you really can't tell by looking. However, as the disease progresses, you may see some physical changes, of course, to one's appearance. I always throw Nurse Jackie in here and say, that probably would have been too obvious if I would have had her in the previous slide. But if there's any Nurse Jackie fans, that she was typical of someone who had a substance use disorder and was using, diverting, all that kind of stuff that goes along with it at her job. Some liabilities for healthcare. These are really in place before COVID hit. And then I think when COVID hit, it probably made it, 10 times worse. I'm sure a lot of you can relate to working long hours, maybe having high stress jobs, picking up extra shifts, dealing with staffing shortages. And then, of course, we as nurses in the profession have, depending on where you work, you have the availability of medication that the general public does not have. Nursing is stressful. We deal with life and death situations, and loss can be difficult. Sometimes if you work in a fast paced or you're short staffed, you don't have a lot of time to decompress if you have a really stressful case, or maybe one of your patients has passed away on your shift, and you don't have a lot of time to decompress before you're getting assigned another case. And some nurses, unfortunately, will self-medicate to cope. When we talk about some warning signs, these are just things to look out for when you are dealing with someone who has a substance use disorder. There's typically an increase in tolerance, the amounts and frequency. Maybe they started off using drugs orally, but that could progress to using it IM or IV. Oftentimes there's changes in personality, their defensiveness when they're confronted about their use. They may make excuses or promises to stop. They lie, deny, blame. Changes in their lifestyle to one that's more centered around their substance use. There's typically trouble at home, maybe school and or work, that stems from their use. And you may see some withdrawal from family and friends, colleagues, activities. If you all are used to getting together, after work, periodically, monthly, every couple of months, and you may all of a sudden notice that this person starts to withdraw from those activities, those are just things to be mindful of. Signs and symptoms when we talk about job performance, these are things that you would consider maybe to be red flags. If there's a nurse that you're working with that has frequent medication errors, they're not documenting their waste properly. There's a lot of errors around that. There's a lot of controlled drugs that are either spilled, broken, the charting, issues with charting, whether that's just illogical, doesn't make sense, it's sloppy, there's no charting at all. You can't find the nurse sometimes. Maybe they're frequently absent from the unit. They're constantly taking restroom breaks. They may come to work early, stay late, or come to work on their days off, make up excuses to come to work, volunteer for overtime. They consistently volunteer to administer other nurses' medications, specifically controlled substances. And then, of course, they wait to access medications when they're completely alone, nobody's around. I'm sure many of you, depending on where you work, you have access to maybe the Pyxis, Omnicell, or AccuDose, whatever it's called in your facility. And sometimes pharmacy, of course, will do reports. And another red flag would be a peer that is considered a higher user among their other peers. We frequently will get those reports here at the board as part of the investigation. And there could be a reasonable explanation for some discrepancies, but you have to combine your observations of some behavioral, physical signs, and that should, it should just warrant concern when you see a lot of these things for an individual. Now, okay, there we go. Sorry. What impact does substance use disorder, of course, have on patients? Well, for one, if a nurse is impaired at work, they're putting their patients at risk. There is a strong likelihood of denying patients the appropriate pain relief. And then there's the potential for overdose if subsequent doses are adjusted based on the lack of pain relief. And what I mean by that is, if a nurse is indeed diverting medications or they're substituting a medication, but they're documenting that, they did give the patient what they were prescribed for pain relief. And then the patient is, complaining to the next nurse on the next shift that they're not getting the adequate pain relief when given their medications. Well, if that nurse calls the doctor and gets an order for something stronger, if the patient wasn't even getting what they were originally prescribed in the first place, but then all of a sudden you start giving a much higher dose, there's a likelihood that could have effects on the patient. And then, of course, we're talking about falsification of records. If someone does document that they give a medication, but they don't, they substitute it. And then theft, any diversion of medications is considered theft, even if if it's coming from the waste or you're taking it from the sharps container. Nurses will certainly justify that it was only waste or that it was going to be trash, but still, it is theft. And what can you do? When we talk about examine the culture of your organization, think about your own attitude towards substance use and, think about where you work. Is it a place where someone would feel comfortable coming to you or coming to management and asking for help? I really encourage you to do that, to think about that. Think about your own personal attitudes. And, make sure that individuals know where they can go to even ask for assistance. And then just education. I can't emphasize enough, just educating staff, regarding their attitudes towards individuals with substance use disorder, and thinking about patients that they care for that maybe have a substance use disorder. I know I can remember back when I got out of nursing school working in the hospital, and you would have the patients that you would that some nurses would stereotype, as the frequent flyers, or that they were constantly coming in and they were just drug seeking. So you think about that. If you're working with a nurse and those types of terms and the stigma and stereotypes are being thrown around, is that nurse going to feel comfortable, talking to you if they're in trouble with the disease? And then, of course, having, detailed policies and procedures for how to deal with someone who has a substance use disorder, because you certainly want to increase the likelihood that a nurse will be identified so that they could get the assistance that they need, instead of just simply terminating the nurse, because then they could just go to another facility and start doing the same thing and put other patients at risk. So think about that. And when you intervene, of course, knowing the baseline performance of an employee is always important. This may be completely normal for a person to have an unkept appearance, or maybe a tremor, or, it may not be because they're, in withdrawal or anything like that. That might be normal. There could be a medical explanation for it. Of course, observe behaviors, their appearance, utilize a second person as a witness, document their signs and symptoms in detail. Hopefully you have an objective checklist in place that you're using. Of course, I'm sure you're used to requesting for-cause urine drug screens, but really making sure too that if you're suspicious about a particular substance that is coming up missing, certainly make sure that drug is being tested for in the panel. We've seen instances of that happening before too. And then interviewing patients, especially if there are complaints that patients are not receiving their pain relief after they've been given medication. You certainly want to interview and try to figure out what's going on with that. And then, of course, you can refer, employees to the employee assistance program, encourage the nurse to self-report to the board. And hopefully, if you're meeting with the nurse, that you would encourage that nurse to contact the care program too at the time of the meeting. And inform them that information will be submitted to the board as required. As we talked about, Kentucky is a mandatory reporting state, so the nurse should be self-reporting, but you also too should be reporting as the follow through to ensure that the board is aware that there is a nurse that is dealing with a substance use disorder. So what does the board do? We are very fortunate to have an alternative program known as the CARE program, and that stands for Kentucky Alternative Recovery Effort for Nurses program. Our board, we are fortunate that they do recognize substance use disorder as a disease, and we offer a program for nurses so that they can continue to practice. It was developed to identify and assist nurses whose abilities to continue practicing are compromised by their substance use disorder. And if you didn't already know this, $5 of your annual license renewal actually goes to help support the CARE program. So we're going to spend a few minutes talking about the program and the various components of it. But first, I want to share with you a video. It's brief. If you're familiar with the show The Doctors, This program featured a few years back a couple of nurses who were suffering from a substance use disorder, and they tell a little bit about their stories. So I'm going to show you that.
The following program contains mature subject matter. Viewer discretion is advised.
A silent drug abuse crisis is striking hospitals around the country, so today we're going to bring it to light. It's called drug diversion. Now, you might recall the TV show Nurse Jackie, in which Edie Falco plays that main character, a pill-popping addict who steals drugs from the hospital where she works. Well, get this. This isn't just a fictional plot line. Here are two real-life stories. Hospitals and healthcare facilities are hiding a dirty secret. It's called drug diversion, and in the worst cases, it's caused widespread disease outbreaks.
When I was working as a nurse, my drug of choice was opiate pain medications, mostly pills.
I work as a nurse in Wisconsin. When I was using, I diverted drugs from the hospital that I worked for. It didn't matter to me whether it was Percocet or Vicodin. The opiates were my preference.
It started because I had had an old injury and I was going to a pain clinic.
I started taking drugs after a mild surgical procedure.
I was prescribed Vicodin and Norco.
I found myself complaining of back pain so that I could get more prescriptions from my doctor.
I was running out of my prescriptions, and that's kind of when it started.
It occurred to me one day that we throw away a lot of narcotics, and I decided to start taking them.
It started with small amounts. I would take a pill from a patient, or if there was waste left over, I would use that.
I really liked the drugs.
I liked the way it made me feel. After a while, it just became necessary.
The first time that I took that fentanyl, I had an immediate craving. It was at that point that I would steal it. Within minutes of being in the hospital, I would be in the drug cabinet taking it.
When I was at my worst, I would need medications to get out of bed. If I didn't have any, I would become sick and, just have withdrawal symptoms.
It got progressively worse to where I was taking it every time I was at work.
My addiction got to the point where I was calling in prescriptions with a doctor's ID for about a month before the pharmacy caught on.
I confessed to what I did, and I was very quickly fired. The police were brought in, was charged with like 26 felonies.
I was put in jail overnight. I was mortified. It was the worst moment of my life. That was my rock bottom.
I did get a job in a doctor's office, told him my whole story, and gave me a chance. And to thank him for that, about a week after I started working there, I was calling in prescriptions for myself and under his name. I did that for about 3 months before they caught me. Again, I was arrested, charged with 9 felonies, and I spent about 4 months in jail.
After I was arrested, the board of nursing was notified and my license was placed on probation. I lost my job.
Amy and Kristen now join us, and I know this isn't easy to open up about. And yet I thank you for doing this. Kristen, I want to start with you because here you are working as a nurse, at this point in time stealing drugs. What happened after you were caught?
Well, once I was caught, I lost my job. They fired me. I lost my nursing license, and I decided to confess because I just couldn't take the guilt and the shame I was feeling. So they did end up charging me with 26 felonies. And I ended up with just a misdemeanor and some probation.
Amy, what about you? When you arrived at the pharmacy and police were there, what happened?
I remember arriving, seeing the officer at the counter talking to the pharmacist, and they were just nonchalantly talking, and thinking, he's not here for me, he's visiting his pharmacist friend. It was pretty severe.
So unfortunately, that is a sad reality of typical cases that we will hear here at the board on a regular basis. And those would be two nurses, very similar to what we monitor now in the care program. They would request to be considered for that and go through the process of being admitted to the program. And but it is very sad. Because again, there's such a stigma with the disease. And then as we've talked, that nurses have topped the Gallup poll for many, many years as being the most trusted, respected profession. So when you have a nurse that has a substance use disorder and the stigma that they feel, it's very hard for them to re-enter, the nursing practice and, to be around other colleagues. And then it can be even more difficult to maybe find a job if they also have criminal convictions that go along with their substance use disorder. So when we talk about the program, it is for nurses or applicants who have a substance use disorder. It's a voluntary program. We do not force or cannot mandate anyone to participate in it. It's an alternative to discipline program with what we consider limited confidentiality. What I mean by that is it is not a disciplinary action program, but while the nurse is participating in the program, his or her license, when it is verified, it will reflect that they have been admitted to the care program. There will be a phone number on there if someone wanted to call for more information. But someone calling from the public, the only information that they're going to get is that, yes, this person is admitted to the program. Because of the confidentiality, we don't release any sort of information. The nurse will sign waivers when they enter the program for us to be able to speak with their employer, possibly counselor, probation officer, individuals like that. But still, we don't divulge any personal information of what led or what their the details of their substance use disorder. It is a 5-year program. So the nurse doesn't have to work for the full 5 years while they're in the program. Some nurses don't work for a while they're in the program. They want to really just focus on their recovery and just getting healthier before they re-enter the practice. But as long as they are compliant at the end of that 5 years, they will be able to complete the program. In order to be considered for admission, you do have to have a current license in Kentucky or have applied for licensure. You do have to request in writing to participate in the program. We get those self-reports online. We'll have nurses that email, but they do have to put some sort of a request in writing to be considered. They will submit and have a substance use disorder evaluation, and they have to follow any treatment recommendations following that evaluation until they've actually completed those requirements. And they agree that they won't practice nursing until they've been approved to do so by the staff. We have some nurses that sign what's called a cease practice agreement when they first enter the program, and they're not allowed to practice for until we have some, documentation that they're stable in their recovery, and we have certain things that we follow. While you're in the care program, if you do have a license here in Kentucky, you're taken down to a single state license while you're in the program. And that's part of the nurse licensure compact rules. As long as you meet the criteria when you complete the care program, you will go back to having a multi-state license, but for the period of monitoring, you only have a single state license. The contract that a nurse signs, it's anywhere from 8 to 10 pages. It is a legal contract. Essentially, what they're signing, they're agreeing that they will comply with all of the terms in that care agreement. There are practice limitations included in there, such as perhaps they won't have access to controlled substances for a period of time. They always have to have another nurse or a physician on the facility grounds when they're working. So they wouldn't be able to work in settings such as home health, do travel nursing, such as the work for an agency where they would maybe be the only nurse working at any given time. There's a limit on the amount of hours that the nurse can be scheduled to work. We limit them to 88 hours every 2 weeks. They can't be in a nursing manager or supervisory position for a period of they have to practice for at least 3 years while they're in the program for us to consider lifting that term in their agreement. All nurses that are in the program submit to random drug and alcohol testing, and that is rigorous testing. It's not just a dip test, it's very specialized. And we say it costs anywhere from $1,800 to $2,000 a year for the testing. They're required to check in every single day, 365 days a year, and provide a specimen on days that they are selected for testing. They do have to, again, continue their treatment until they have completed, whether that's counseling in an individual group setting. Maybe they have to do an intensive outpatient treatment program. They do have to attend 12-step group meetings for the duration of their participation in the program. They have to attend 3 12-step meetings a week and also have maintain a sponsor with whom they have twice weekly contact with. There are compliance reports as well that the nurse will submit from various, maybe their employer, counselor, probation officer, so various individuals that we get documentation from periodically to make sure that they are complying. They do have to provide a copy of their care agreement to the individuals listed here. So when they go on interviews for nursing positions, they have to, for one, provide a copy during that interview process. That could be to HR if you have a, whoever the hiring person is that is doing the interview. That might not be the immediate nursing supervisor or manager. That might be someone that's in with recruitment. But they have to provide a copy then, and also once they're hired, to their immediate nursing supervisor or manager. Also to any treating practitioners, anybody that's providing care for them and prescribing medications, we want them to have a copy of their care agreement. If they have a probation officer, and of course their treatment providers, and if they're in a school of nursing, if they're participating there, they have to provide a copy as well. And then we have what's called verification forms that these individuals will complete and return back to the board for us to verify that they did receive a copy of their agreement and understand that they're being monitored in the program. We know that relapse does happen with this disease. Sometimes we discover a relapse by the nurse having a positive drug screen, or they may self-report that relapse to us. They're required to do so within 5 days. If that were to happen, and if the nurse is working in a nursing position, then they have to immediately cease practice. They sign a new agreement. They don't start over in their monitoring, but they do sign a new agreement that says they're going to cease practice. If they're working, they should be notifying their immediate nursing supervisor that they will have to cease practice for a period of time, and they'll have to provide a copy of that agreement to them. They have to undergo another evaluation and follow any treatment recommendations. Sometimes that might mean if they've already completed counseling, sometimes they have to re-engage in counseling. Sometimes that's going back to an intensive outpatient program, or sometimes to a residential inpatient program. It just varies. But they remain out of practice until we have some documentation from treatment providers that they feel like the nurse is ready to return to nursing practice. And then at that time, they will sign another agreement called a return to work agreement, and they will be able to go back to work. So how do you exit the program? There are 3 ways. One is successful completion, which is what our desire is for everyone that's in the program. Once someone does successfully complete from the program, there will be no reflection on the Kentucky Board of Nursing that they participated in the care program. That alert will go away. Another, I know Jeff talked about a couple of these as far as voluntary surrender. If a nurse feels like they cannot continue for whatever that reason is personally, that could be a health reason, that could be they cannot maintain their sobriety, they can request in writing to surrender from the program. And then also they could be suspended for due to their noncompliance, due to their violations to their care agreement. If a nurse does have violations that rise to the level that I would make a recommendation that maybe a notice of intent be issued to that nurse. And that is a document, the notice of intent to suspend, that is mailed to the nurse. It's sent both regular mail, certified mail, that notifies them that the board intends to suspend their license. I know Jeff talked about that. The nurse does have 20 days if they wish to request a hearing. That's part of their due process. The hearing won't happen in that 20 days, but the nurse will request the hearing. They will continue to be monitored in the care program until the point of course, having the hearing, and until a final decision is rendered that Jeff talked about. And then that decision could either be to suspend their license, to continue them in monitoring. It could be whatever the panel and the full board ultimately decides. I always say there is hope, certainly for individuals that have a substance use disorder. These are each month, the nurse in the care program has to submit what's called a monthly self-report to their case manager. At the end of the self-report is an area for comments. These are some various comments that I've received over the years from nurses who are very thankful for the program, talking about how it's changed their life, enabled me to save my career and my family. Another nurse won the distinct award of National Team Member of the Year for her company. And then the other nurse that I've mentioned on here talks about the program seeing them at their worst and hardest moments, but however, you pushed me, you were tough on me, and somehow there was a belief in me. So, you know, nurses are, in the beginning, of course, they may not be thrilled to come into the program and all of the, because it is a rigorous program, all of the requirements that they have to do to maintain compliance. But at the very end, they are very thankful for the program and the opportunity to participate in it. These are just, before we move on to disciplinary monitoring, you know, this slide just talks about if you're concerned, you know, things that you can do to, of course, express concern and support for maybe a colleague that you're working with, notifying your supervisor. I have indicated on here that through the National Council of State Boards of Nursing, through their website, they do have a free course on substance use disorder in nursing. It's worth 4.8 hours. It's a really good course. So I would encourage you, if you know, need some extra CEs, want to learn more about the disease, you may want to check that out. And, you know, the nurse could be angry at you initially if you do report them, but in time, hopefully they will thank you as part of their amends. You could be, you know, you think of it as you could be saving someone's life and doing something for them that they were not able to do for themselves. So I want to move on, switch gears now and talk a little bit about that. The care program was the alternative to discipline. And now we're going to talk a little bit about disciplinary monitoring, which I know Jeff covered some of this as well in his presentation, but we also monitor nurses who enter into an agreed order. And that would be whether they have a reprimand, which is the lowest form of disciplinary action, or maybe they're on limitation probation. Or we also monitor nurses who have a decision, which is the result of if a nurse has had an administrative hearing and maybe they are placed on probation, limitation probation as a part of the outcome of their hearing. We monitor those nurses as well. The thing about disciplinary orders, you know, they are public. They are available online for viewing, unlike the care agreement that is a confidential, you cannot obtain unless the nurse gives that to you as part of being their employer or counselor. But the disciplinary orders, they are public. They're available online. If you verify someone's license on the Kentucky Board of Nursing website, it will direct you for a copy of that to the nurses.com website, where you can actually obtain and view a copy of the disciplinary order. And it depends on, you know, the type of violation, what sort of monitoring terms are included in there. Generally, nurses who have that disciplinary order are monitored for anywhere from 1 to 5 years. They also have a single state license during the period of monitoring. And the big difference too, in care, they didn't have to work for that full 5 years. But when a nurse is on probation, now not a reprimand, but a nurse that's on probation, generally they're on probation for 18 months to 5 years. They actually have to work in order to complete that monitoring. So if the nurse is on probation for 2 years, they have to work in a nursing position for 2 years in order to be eligible to complete their monitoring. So if they're required, if you think about it, if they're required to do drug screening, they have to go ahead and activate their account with a drug screening company. But if it takes them 6 months to find a job, they may be drug screening for that period of time while they're trying to find a job. Their probation time ultimately doesn't really start until they start working. They agree to remain free of, any type of alcohol, all forms over the counter, alcoholic beverages, and remain drug free. They do have to provide verification of their medications, and a lot of times they are required to submit to the random alcohol and drug testing as well. Typically, you will see it for someone that's on limitation probation, you will see some practice limitations, and that again could be, a limit to their access of controlled substances. That could be having that on-site supervision by maybe another nurse or a physician. That could be the amount of hours that they can be scheduled to work. Also, they are not permitted to work in a supervisory or manager position. They have the limited work settings typically as well, like such as travel, nursing, home health, not working for an agency, things like that. They do have to provide, nurses who have an agreed order or a decision, they do have to provide a copy of that to their employer, counselor, if they have a counselor, their healthcare providers, if they go back to nursing school, they provide a copy of that to everyone. And then they meet with board staff as requested. Both nurses that are in the care program and nurses who are being monitored through disciplinary orders, they're all assigned a case manager for monitoring. So we all have caseloads, various caseloads, and we meet with nurses typically initially to go over all of those terms and ensure that they understand what they will be, held accountable for, make sure that they understand the documentation that they will need to provide at various times in order to remain compliant, go over all the drug screening requirements with them. And then we serve as, of course, a resource. So we meet with them, try to meet with them annually. First it's initially, then annually. And so throughout the year, we have nurses who are constantly on our caseload who will call us or email and ask various questions, reach out at various times to update us of changes and that to their employment or maybe medications or travel or whatever it is. Typically, if it's a nurse that does have a substance use disorder and they're placed on some sort of disciplinary monitoring, they typically will have to do 12-step meetings as well, and also have a 12-step sponsor that they're maintaining regular contact with. Typically, what you'll see in the agreed orders or decisions is there will be some continuing education component that they'll have to supply the certificates to their case manager to verify that they completed that. And also they have a civil penalty that they have to pay by a certain due date. They also have compliance reports, just like care, that they have to submit at various times. These are just some of the various reports that they'll submit. And then it's really the same thing as far as the completion of monitoring. A nurse can successfully complete their disciplinary monitoring. Now, at the time that a nurse that completes that's being monitored for like a disciplinary order, an agreed order, or a decision, when they complete, if someone verifies their license, what that will reflect, it will say previous disciplinary action by KBN cleared on such and such date. It will have the date there. Now, unfortunately, you can still obtain a copy of their order, by going to the nurses.com. Jeff talked about the, expungement and those dates. They vary, but that disciplinary order does stay as part of their record when you do verify their license, even though the alert will reflect that the previous disciplinary action has been cleared. But then also we do have nurses who are in disciplinary monitoring who request to surrender their license for various reasons. They just cannot maybe maintain compliance. We've had some nurses who have had difficulty finding a job. And so the cost of the drug screening is just too expensive for them to continue. So they, just because of financial reasons, maybe because of health reasons, it just varies the reasons that a nurse will request to surrender. And then also nurses who are being monitored as part of the agreed order or decision, they could also be subjected to suspension if they are non-compliant and they have violations during the course of their monitoring as well. And we follow that same process for the notice of intent to suspend, to give the nurse the opportunity, if they wish, to request a hearing within the 20 days following the issuance of the notice of intent to suspend document. So that's really just a brief overview of both the care program and, nurses who we monitor through disciplinary orders, such as the agreed orders or decisions. We really appreciate your all's time today, and this is my contact information there. Should you ever have any questions, I'd be happy to answer about our branch. I'm going to stop sharing at this point, and I think I'm going to make Eric the host, I think. Yep. And I think at this time, all of the presenters are still on here, I think. Maybe not. But we were going to open it up for the last, 30 minutes or so. We've allotted 30 minutes for questions. So we really would encourage you all to ask questions. You have the chat box. You also have the Q&A. You can ask questions in either of those areas. And then if we needed to unmute someone, I think Eric can do that as well. If someone needed to ask something more specific, or if you wanted to have a little bit of dialogue. So are there any questions now? Let's see, I haven't opened up
The chat.
Okay.
There is a question. With these practice limitations, have nurses had more trouble finding a job? Has it been seen that hospitals avoid hiring?
That's a good question. Yes, it is difficult, of course. I think it depends on the circumstance. Again, if you have a nurse who maybe has restrictions on their license, and then, couple that with convictions, it really just depends on the situation. I will say during COVID, we've maybe had more nurses, I think because of the shortage and just the demand in that, we have had more nurses, I feel like, who have gotten hired. Historically, it is, just speaking in general, hospitals are not as open to hiring nurses who are in the care program or who are being monitored through a disciplinary order. Sometimes if the nurse is already working there and the employer wants to work with them and maintain their employment, we have nurses who are working in the hospital that way. And some hospitals will certainly hire, but I will just say in general, we don't have as many nurses working in that hospital setting as other settings.
There's also a question about SRNA, specific resources for SRNA scope of practice. The Kentucky Board of Nursing really only keeps the registry for state registered nurse aides. The curriculum is housed under the Kentucky Community and Technical College system. So, and I believe that the Health and Family Services for Kentucky is the one that really oversees nurse aides. So perhaps you may want to check that website for resources. Let's see, with the issues that happened with the nurse in Tennessee, I'm curious if the Kentucky Board of Nursing has ever changed a decision and how that would look.
Ever changed a decision? And you mean where the a case was reviewed and determined to not have enough sufficient evidence and then subsequently prosecuted and then reopened for discipline? Is that the question?
Yes, the individual says that's correct.
Okay. I think when cases are closed, generally speaking, they're they're closed, and there's a statement that at this time there's insufficient evidence. Now, I don't know exactly if in that case in Tennessee, as I recall, I don't remember seeing anything there about, if there was subsequent evidence or if they made their decision, what they made their initial decision based upon, and then there was subsequent evidence. However, if there was a case with the board where there was insufficient evidence and the case was closed, the licensee would be made aware of that. However, if there was sufficient, more evidence came to light later, there would be nothing to stop the board from reopening that matter and reviewing it. And then at that point, the licensee would, I anticipate, be notified to say, at this point, we're going forward. Now, of course, the licensee always has the history of how the case is processed. And that's an argument to be made, is like, well, you closed it once and now you've reopened it. And I mean, those are arguments that a respondent could make. But there would be nothing stopping the board from procedurally reopening the case and investigating based upon new information that came to light. There's no limitations on it. Where that, if it's closed and it's not pursued within a certain period of time, at least there's no statutory limitation. Does that answer the question?
They say thank you.
You're welcome.
Someone would like to know if they can get the slides and print the slides after this is completed.
I would think so. Is that we generally make them available, don't we?
Yes, we generally make them available. I would just ask that you please, I put Michelle Gary's email in earlier. I'll put it in the chat again. Please send your request through her and she can send you a copy of the slides if you wish them. The second looks at when a nurse retires from a paid job, what are the requirements to maintain licensure as an RN? Are there any requirements beyond the mandatory CE requirements for all RNs?
Myra, I thought you'd tackle that one for me. You can not be a practicing nurse as long as you do your CEs and pay your renewal. There is no mandatory requirement for hours worked. However, if you choose not to renew and let your license lapse, and it lapsed for several years, there are requirements for a greater amount of continuing education requirements.
An RN BSN who recently has a primary mental health nurse practitioner certification, how many CEs are required total? Okay, so with the APRN and CE, you need to keep your current certification. Your current certification that you have to have, you generally are required to get more than the yearly 14 CEs. So the only thing in addition to keeping current certification is that you have to have the 5 hours of pharmacology every year. So for an APRN, it's 5 hours. For an RN BSN, it's regular 14 CEs every year. But certification can count as part of those CEs. So does that help? Is there a direct link to the registered scope of practice that you can provide today? Thank you in advance. Do you mean the decision tree? Or are you talking about statutes and regulations?
Looks like they said no, just the scope of practice for the RN.
Well, scope of practice is in your Nurse Practice Act. So
I can just put the statute the 314 11, but it's not going to give you a ton of information. It'll just give you the basic statutory guidelines for it. But I can put a link to KRS and the KAR and even the AOS is in the chat so they can click through them and go there.
What is the best way to refresh nursing knowledge for someone who has kept a license but not practiced much since graduation? There's a couple ways. Sometimes your organization or facility who hires you is willing to provide that additional education and guidance. Refresher courses are good, but as far as I know, there's only one refresher course in Kentucky, and that is through West Kentucky Community and Technical College. And the individual who oversees that is Sherry Golson.
Has the question regarding the flow chart been answered? Where do we access the flow chart used in the presentation?
That's on the website under advisory opinion statements. Are there any legal issues with APRNs working as RNs?
There are not. And I say generally a lot, and I'm going to say it again, because I guess that's why they call me the general counsel. However, APRNs, every nurse, every licensee is held to their highest standard of licensure. Okay, so even if you're working as an RN, but your training is as an APRN in one of the focus areas, you will be held to that higher standard of education and experience. If there is an allegation of, say, a practice violation.
So the question is, are there classes an RN can go back to into the acute care setting after practicing in remote case management for years? Again, the only refresher course that I'm aware of in the state is through West Kentucky Community and Technical College. And of course, some acute care facilities are willing to train individuals who go back into the acute care setting. So it really depends on the facility. If anybody else has any information on the panel that can help this individual, please feel free to share that.
No, Myra, I was just going to suggest the refresher course as well.
If anybody would like, if you send, I'll put my email in. If you send me your email and you want to contact Dr. Golson, she may also have other resources that I may not be familiar with. So she is a wonderful resource if you want her name. And I will put my email in the chat. Any other questions anyone has? We've got all these wonderful panelists who are here to answer your questions. Okay, I'm putting Michelle's email here as well. Does the certified nurse educator certification count toward continuing education? Yeah, certification hours that you get to maintain certification would count towards CE, absolutely. The certification itself, generally certification comes with hours. So we would need not just the certification, but how you achieved it. But yeah, send it in and we can evaluate that. Any other questions? Oh, in the Q&A. Can someone remind me of the 2 new CE required for October renewal? I think you're talking about suicide prevention and oh my gosh, came right out of my head.
Implicit bias.
Thank you. Thank
You're
you.
welcome.
Those are the 2. Thanks, Jeff. I have a PLLC and work projects as an independent contractor, such as education, PowerPoint presentations. Could I take a job in a non-compact state, or do I need a license there? I'm going to let Jeff field this, but I would think if it's as a registered nurse, and it was a non-compact state, then you would need to get a license in that state to do your work.
Right. Work projects, independent contractor, education, PowerPoint presentations. It's kind of a broad question. And again, I can't give you legal advice, but if the projects as the independent contractor and the education has to do with nursing, then you might want to even check with the non-compact state to see what their rules are about whether or not you would be practicing without a license within that state. But I would, if it's not nursing care, I mean, I would contact the state, because they're the ones that you would be practicing without a license in their state if you're practicing without a license. So I would check with them.
And from an investigator point of view, look at that job description. Are you using nursing knowledge for any of it? Are you pulling on that nursing knowledge? And does that job description have anything to do with nursing? Those are key points. And there's a question regarding, I continue to get questions about family nurse practitioners working in mental health clinics regarding scopes of practice thoughts. I would ask you to send those as well to Kimberly Richmond, and those can also be forwarded to our APRN investigators within the investigation and discipline branch, because that is a rising topic among APRNs of family nurse practitioners practicing in mental health clinics. Yes, so we are aware of that. And our APRN investigator, Ellen Thompson, in the investigation branch. Let me put her email in the contacts. And you can also reach out to her regarding that.
What was the second required CE? It's suicide prevention and implicit bias.
And there's a question there, is the KNA going to offer CEs for mandatory license requirements? I think they are. Is that right, Myra?
Yes, and I believe it's supposed to come online May 1st.
Okay. So yes, they are developing that. That's my understanding.
Are those both required for RN and LPN? It's required for all nurses, the new CEs.
There was a question there from Cindy Cobb, a couple, 2 or 3 up from the one you just answered, Myra. As a nurse educator, could I develop a class for an LPN who has not had experience in an area such as blood administration to get that nurse up to speed on that skill, or would they need to pick up a class or do some kind of CE? Was that answered?
I don't think so.
Okay. One of our practice consultants want to take a shot at that one. Oh, we're thinking about that one. No, the CEs for suicide and implicit bias do not have to be provided by the KBN. You can, if you have a CE, if there's a provider that meets the requirements, then you can obtain the CEs through them.
Sorry, I've been talking on mute to myself for a solid minute.
And I'm sure it was all very informative too.
Well, then my dogs are barking out, but I just can't. So in regards to the CEs for blood administration, we have an advisory opinion statement that kind of talks about any nurses who need up to speed on infusion therapy, including blood products. And the general response that we give as consultants is that we don't have a specific requirement for how this is met. So it can be from your employer, whether it's a class or whether they choose to go through a class that is provided online or in person. As long as we have documentation that they are either educationally prepared and clinically competent from their nursing program, or it can be an on-the-job training, as long as that sits in their employee file to show that they are competent to perform a task. I don't know if it's something that we would want to talk about. Ellen is on the call if we wanted to hear her thoughts on the FNP role being psych mental health, or we can not bring that to discussion in either option.
I think they should just email her based upon the time limits. Any questions that anyone might have regarding that?
Dr. Richmond, did you answer it? Was there was the follow-up regarding from Cindy Cobb? Would that be true for any skill within the scope that but had not been officially trained through a school or within a school?
Yeah, as long as your organization has a policy and procedure for how nurses are trained. So every nurse would get that same standard of care and education. And so it's something that is vetted, and it's your organization's policy and procedure, not just me today. I thought this is how I want to teach someone how to do it. And so just ensure that you are doing organizational policy and procedures on how you would educate someone. I think I gave the example in my presentation of we're all taught how to put Foley catheters in a nursing school, but how many people actually are still doing it or haven't ever done that? And so it's just something ever fresher you get checked off on, that you are clinically competent to do a task. I just always ensure that we are doing things within our organization, how they would do it across the organization, to ensure every nurse is trained the same way.
Okay. Are there any other questions? Okay, we're coming up, we're about 5 minutes out from, I guess, our 2-hour limit. Is that right, Ms. Blazer? Chrissy? Okay, so I guess if there are any other questions, I think you have our contact information. If you think of something after the 2-hour time frame, after we go away, feel free to reach out to us, and we'll do our best to answer your questions. Thank you all.